plastic surgery you can see here. That's great. Great to see you all.
Thank you, sir. Thank you.
Ma'am, can we start?
Angeline ma'am is there?
Yes, I think
ma'am.
we should start.
Angeline ma'am.
I am
Yes,
there,
ma'am.
madam. I am there.
Madam, this is very tough today for you. Six teams are there.
That's it. I just want to know how you are going to proceed now.
I'll tell
Rules.
briefly. I'll tell you, ma'am.
Rules for the team.
Yes, yes.
And for us.
Actually, 6 teams, but one team not participating because their pre-finals are going on. Time is up, so we'll start today's program.
Yes, yes. We can start.
It is my great pleasure to welcome all of you for the pre-final session of Plastiquest Challenge in Burns in association with the APBC. I welcome behalf of the team of Plastiquest and team of APBC. I welcome all of you people for today's session. This is which we are going to conduct online, and final is at the APBC conference. And today's judges are Dr. R.K. Srivastava sir from Safdarjung Hospital, and Dr. Sanjeev Uppal sir, and Dr. Angeline Selvaras madam. Dr. Vijay Joseph sir is unable to join for today's session. So I welcome all our 3 esteemed judges. And today we have 6 panelists because we thought 6 teams got selected. So 6 spotters we will keep and 6 panelists for the session. But PG team from Jaipur could not able to join due to the pre-final session exams. So I welcome our panelists of today, Dr. P.V. Sudhakar sir, Dean NRI Medical College from Vizag, and Dr. Arun Bhatnagar sir, who is joining for the first time in Plastiquest Challenge, Professor HOD, Mahatma Gandhi Medical College, Bhopal, and Dr. Durga Karki, Director Professor Safdarjung Hospital, New Delhi, and Dr. Nikhil Panse, Professor BJMC, Pune, Dr. Uday Balakrishna sir, Professor HOD, the Nair Hospital, and Dr. Sailesh Ranade, Senior Consultant, Hinduja Hospital. He is also for the first time he is joining. I welcome all of you.
ठीक आप जब खाली होंगे आ जाइए हाँ खाली करो
And 6 teams
खाली हो जाएंगे तो आ
joining
जाइए
for today's session. Dr. Rohit will welcome all these teams one by one. I extend my wishes to them. Wish you all the best. And briefly, I tell today's proceedings. There are 5 spotters for 5 teams. As Jaipur is not there, Jaipur. Don't think why they call. Okay. I think Rohit, there are 6 teams. The
Yes,
Jaipur
ma'am.
team
6 teams.
is not in pre-finals.
Yes,
So
ma'am.
all 6 teams are there. There is no problem.
Yes, ma'am.
Okay.
We have 6
So,
teams, ma'am. 6 spotters.
yeah, 6 spotters. So as to all are estimate teachers, and they are very experts in the field and well known to all the teachers. So only the first time who are joining, the 2 panelists, they will be introduced by Dr. Devi Prasad Mohapatra sir.
Devi sir.
Good afternoon, everyone. It is my privilege to welcome Dr. Arun Bhatnagar sir, who has joined the Plastiquest family for the first time. For the benefit of the younger colleagues, Dr. Bhatnagar sir is the professor and head of Department of Burns and Plastic Surgery at Gandhi Medical College in Bhopal. He is the ex-president Association of Plastic Surgeon of Madhya Pradesh and coordinator of Medical Education Unit for Faculty Development. I welcome you, Arun Bhatnagar sir.
Thank you, sir. Thank you.
Welcome, sir. And it is also my privilege to welcome Dr. Shailesh Ranade, sir, who is a consultant plastic surgeon and coordinator of burns unit at Bhatia Hospital in Mumbai. Dr. Ranade, sir, is quite well known in APSI Apsicon group. And sir is a consultant plastic surgeon at PD Hinduja Hospital, National Hospital in Mumbai also. Welcome, Shailesh Ranade, sir, to
Thank
this
you.
meeting. Welcome, sir. With this, we'll proceed further.
Sir, I will just take the roll call, sir, for the PGs which were teams which were here. BGMC Pune.
Rohit, we can proceed with the session because 6 teams already there.
Yes, ma'am. Yes, ma'am. Then we can.
Welcome the PGs and only few the rules and regulations. There are 6 spotters. So the first spotter will be discussed by the first panelist.
Team one.
We will be announcing them. And the primary panelist will discuss the spotter for 10 minutes, 2 questions for each team. And later, other panelists and the judges will ask one question to each team. Anybody can ask, but in order we will allow. And the judge of the spotter will give the gist of the spotter at the end for 2 minutes. So the second spotter will be discussion starts with the second team by the second spotter, second panelist. So third panelist will be starting with the third team. Every direct question, correct answer, 2 marks. Any dispute or any controversy, the judges will decide. Our patron, Dr. V. Bhattacharya sir also will clarify the doubts. And so it goes on like that. And our judge, Dr. Angelina madam, always will be taking nice care of giving the marks. So I request madam to take care of the marks. So Rohit, I hand over to you. Please go.
Madam, one question is, first team will be asked. So if they don't answer, does it pass on to the other team or is it just the first team that is answering?
No, madam, it will be passed on the same way. 2 marks for the direct answer and the 1 mark for the past. And the panelist will tell half answer is correct or as usual. If partially answered, 1 mark will be allotted.
Okay. Okay, madam. Okay.
Okay, ma'am. Now I just want to clarify. The team order will be, first team will be Sri Gangaram Hospital. Sir, Gangaram Hospital, New Delhi will be the team 1. Second team will be Seth GS Medical College, Mumbai. Third team will be Jipmer Pondicherry. Team 4 will be AIIMS Bhubaneswar. Team 5 will be Southeastern Railway Kolkata. Team 6 will be BMC Bangalore Medical College.
Yeah.
So this will be your order of teams.
Yes.
So first spotter will be.
You just ask them to introduce themselves and then show the spotter and tell the panelist and invite the panelist and start.
I would like to welcome the PG teams who are contesting to just introduce themselves one by one.
No, single, the team 1 you
Team
invite
1?
and they will introduce and start spotter 1.
Okay, ma'am. Team 1. Gangaram Hospital. PGs from Gangaram Hospital.
From Sir Gangaram Hospital, 4th year resident. I am Dr. Nistha Sahi from Sir Gangaram Hospital, 3rd year resident.
Okay, ma'am. We'll go to the spotter 1. I would like to request PV Sudhakar sir, Dean NRI Medical College, Vizag, to start questioning.
Yeah. Welcome, team Sir Gangaram Hospital. Can you please, this is a patient, an young man who had self-immolation, at an attempted self-immolation. Can you just see him and let me know as to what are you going to do when you are at the spot of self-immolation? There are chances when people are at the spot of self-immolation. What are you going to do at the site of incident whenever there are burns of this type?
Sir, can you please repeat the question? The internet connection got off in between.
Yeah, this is a self-immolation. This is a patient who had a self-immolation. If you happen to be at the site of an incident of a self-immolation, what are the steps that you take?
You are at the accident site where he committed suicide.
Okay. Okay, we'll first remove the offending agent. We'll try to stop the fire, and initially we'll assuming that this is thermal burn. It is flame thermal burn. Then we would like to either put sand over the patient or water over the patient to douse the fire. That would be first strategy at the site of accident. And we'd prefer that the patient drops and rolls so that the fire is doused. Then we would like to once the fire is doused, we want to we'll take the patient out of the site, and we'll first stabilize the patient on site, and we'd like to assess the ABCs of the patient in the primary survey, the airways, breathing, and the circulation of the patient.
When such a patient is brought to your emergency room, in the serial of what are you going to do?
This is the second question, sir.
Yeah.
First question, 2 marks.
So in the emergency room, we want to look whether the patient is conscious or not. We would would want to assess the patient for inhalational injury. For that, I would want the history whether there is burning in closed space. I'd also look for whether there is cinched nasal vibrissae, or if there are soot particles, there is carbonaceous sputum, and other signs of inhalational injury. And because I would want to assess the patient for intubation before the airway edema sets in. And I first look for the vitals. If he's not able to maintain the saturation, then I'll go for early intubation, as it is a case of facial burns, and we suspect inhalational injury in such cases. Then we would look for breathing, whether breathing and then circulation. We'll secure the 2 large bore IV cannulas, and then we start the IV fluids according to the Parkland formula. And first we
would require intravenous fluids.
Yes, sir.
What percent of the burns would require intravenous fluids?
More than 20% burn, sir.
Okay. So when do you call it as a burn shock?
Sir, it second team. This is third question, no?
Yeah.
Second team, please answer the question.
In case of a burn shock, there will be vital derangements of the patient, decrease in blood pressure, tachycardia. Patient will be in tachypneic situation. Also, urine output will be less than 0.5 to 1 ml per kg per hour.
No, it's okay. What is, I mean, are we going to the next team for the question, or are we going to continue with this?
No, sir.
Next team gets
third
how
and
much
fourth
marks?
questions.
Yeah.
For the second team, you asked one question, and one more is to be.
Can we give full marks, sir?
Please tell the marks.
Basically, I was asking them about from what percentage.
How much mark should be given to them? The second team. Full marks or half?
Hey, I think we will disclose this on the later side. I think end of the.
No, madam. No.
For every answer, you have to tell them the
Marks.
judges that how much marks may be given to them.
Yeah. Team number 2.
Yes.
Yes, sir.
Yeah.
Yeah. Now, my question is, what percentage of burns normally in an adult would end up in a burn shock?
Sir, more than
More.
25% of total body surface area will be ended up in burn shock.
Okay. Then tell me the 2 important factors which would determine the admission into a burn shock.
Sir, percentage of total body surface area involved, which is usually in adults more than 15 to 20% of involvement, and the site of involvement of the burns, if it is face, eyes, ears, and genitalia, and inhalational component.
Wait,
It is
the 2 important factors would be the total burn surface area and the age of the patient.
more age and more age. Extremes of age needs admission.
Okay.
Burns unit.
You can give half the marks for this second question. The next.
1 mark, sir. 2 marks.
Yes,
Half marks, 1 mark.
one.
Okay, sir. Madam,
1 mark we have given.
sir, just for clarity, every spotter you have to ask 2 questions to each team, sir. Total 6 teams.
Got it.
Now you are done with the questions for this team, na, sir?
Yeah, we have done with both the questions. 2 plus 1, 3 marks for them.
2 plus
Yes.
1, 3 marks.
Okay.
Now we move to team 3.
Team 3.
More
Team-
clarification.
Yeah.
One more clarification.
Team 3.
That when you are asking primary question to the other team, they should be given 2 marks for correct answer. Because you are asking 2 questions from each team, 3 teams.
Yeah, that's what I understand.
Yes, sir.
And if you are asking and giving 2 marks to first team for correct answer, then you should give third and fourth answer to second team.
Yeah,
2
that's why we have
marks.
3 marks, 2 plus 1.
For the
It is only for passed on.
No, sir, no, it is for the second team. The questions were asked, and we have given 2 and 1 for the second team, sir.
Yes.
Fine.
And now the third team.
Yes.
2 questions.
Yes.
Time, third team. Can you have seen that picture?
Yes, sir.
Can you tell me as to what are the different degrees of burns in this particular individual and why?
Sir, there is a mixed second degree superficial and deep burns in that the right forearm and areas on the chest and few areas on the left forearm and arm are second degree superficial. Second degree deep are mainly present in the anterior aspect of the neck, the patch on the right medial arm and left medial arms.
And the chest.
Chest also, central area, there is mottling which says it is deep.
Question number 2. This is okay. Question number 2 is, what is the difference between the second degree superficial and second degree deep burns morphologically when you look at it?
Sir, second degree superficial burns, they'll be reddish in appearance, and on blanching, they'll blanch on touch, and they'll have blisters and pain will be there. While in second degree deep burns, there will be mottling of the skin, whitish appearance will be there, and blanching won't be there on pressing, and it will not have pain, and hair will also be
easily pluckable.
Okay, 2 plus 2. Number 4. Team
4.
Good evening, sir.
Good evening, sir.
Yeah. Looking at the individual, what can you make out?
Sir?
Looking at the face individual, what can you make out?
What can we make out, sir?
Yeah.
So since this is a case of self-immolation, we can make out that there is the anterior chest wall, bilateral upper limbs are involved along with the neck and facial burns, which also gives us an indication that this might also lead to inhalational burns. So the patient is to be evaluated adequately for the airway and breathing first, and then resuscitated in the acute presentation.
What will you do with the burns at this point of
Sir, pardon, sir?
wound care for this particular patient?
Wound
So we would like to first proceed with the dressing, initial dressing, and then assess the wound after 2 days, and proceed with, because there are areas of deep burns involved. We would like to then proceed with the planning of a tangential excision of the deep areas, along with the once the resuscitation is completed, and give coverage usually, because we can see that only the above the waist area is burned, so thighs are spared. So we'll give a cover with the autograft.
Okay, both the questions answered. The next team.
Team 5.
Good evening.
Good evening, sir.
Yeah, good evening. Team 5. What is the resuscitation method that you use, fluid resuscitation that you use, and why?
So we use a Parklat's formula, sir, for resuscitation, sir. So we calculate it as 4 ml per percent of body percent body surface area burnt into the body weight. And so the 50% of it is given in the initial 8 hours, and the remaining 50% is given in the next 16 hours.
What is the sodium content in ringer lactate?
135 to 145 milliequivalents.
Pardon?
135 to 145 milliequivalent.
There is no 2. There will be only one. Yeah, it is 130 milliequivalents per liter. Okay, 2 plus 2 plus marks for this particular.
2 plus 0, na sir?
2 plus 1.
2 plus 1.
Sorry, 2 plus 0. 2 plus 0.
2 plus 0.
Next.
You can ask the other team if
it may be passed on.
Okay, I've already answered that. So,
Okay.
Team 6.
Good evening, sir.
Yeah, good evening. What are the likely complications that this particular individual will encounter?
The first and foremost is, sir, since the patient looks has more of inhalation burns, the first thing I encounter is difficulty in breathing, and that's the first thing. And like since there is in left upper limb, there's a circumferential burns I can make out. He can have compartment syndrome. So these are the 2 complications that first I'll encounter. Sir.
Okay, how soon do you have to deal with the circumferential burns, and why?
Circumferential burns, once the patient airway is secured and the initial resuscitation has been done, and we should assess for the the 6 P's, the pulselessness, pain, all those, and edema, all those things. Then we'll encounter. First is the airway management and the resuscitation, sir. After that, we'll go for the circumferential burns management.
No, how soon do you have to intervene?
Within 6 hours of the injury, to prevent injury to the muscles.
Yeah, okay. 2 plus 2 for the 6th team.
Okay, sir.
Sir, questions for all the teams over.
Yes.
So we'll go to the judge. Other panelists, one question. Seniors or other panelists? For team 1, anybody would like to ask any question related to this Potter?
Ma'am.
Judges?
To which team we should ask the question?
Sir, this is now team 1, one question only.
Okay.
Each team will get one question from anyone.
Total 6 questions, sir.
6 questions.
Okay.
One per team, sir.
Team 1, can you assess the difference between homicidal burn or accidental burn and suicidal burn clinically? The patient has come to you in emergency. Can you assess that it might be this by seeing
Team
the
1.
patient? This is question for team 1.
Assuming that this is flame thermal burn, if it is a homicidal burn, then the person would try to protect his face with his forearms and hands vigorously. So we would be able to appreciate more burn surface over the forearm and hand which the person used. And in um, accidental.
No. Team 2?
No marks, no, sir?
No, no marks.
Sir, in usually homicidal burns, usually olar aspects or the palm of the hands and the face and anterior part usually will be spared by the protective mechanism. Pugilistic attitude will be there. In self-inflicted, the olar aspects and the anterior aspects are more commonly involved, sir.
And there will be history of
I'm saying no history, just by seeing the patient.
So more of olar aspects and anterior aspects and face is involved in so suicidal or self-inflicted, and these palms and olar aspect will be protected by the pugilistic attitude, and even face will be covered, less involved in homicidal, sir.
The answer which I want is not there, though you are giving some points.
Sir, you can ask third team.
Third team.
Sir, in suicidal burns, the right hand or the main working hand will not be involved and the arm associated. And then in the homicidal, sir, the
No,
patient will
fourth
try to...
team.
Sir,
Case of
it will be non-uniform and splashes in case of homicidal burns because they'll try to escape, sir. Whereas in case of and also the defense attitude will be seen, and we in case of homicidal burns, the extensor aspects of the arms will be involved, forearm and arms. Whereas in case of suicidal burns, the more accessible.
Team 4.
In case of accidental burns, sir, most common accidental burns that we see are due to diyas catching fire or saris catching fire. They're most likely from bottom up. That is, the lower half of the body is involved in accidental burns. Whereas in suicidal burns or self-immolation burns, where people pour kerosene or any inflammable liquids on themselves, it is the face, neck, and the upper chest and the upper limbs that are more commonly involved.
Okay, right.
Correct.
2 marks.
1 mark, sir.
2 marks.
1 mark, sir. It's a past question.
It is past question, then 1 mark.
One mark. 1 mark.
But in this case, it should not be taken as past question. Or should I go again for second team?
No, sir. Now only you asked team 1, na? That is passed to 4. So team 2 should be addressed with one direct question.
Now team 2.
Yeah, yes.
Now team 2.
Yes.
What do you expect by seeing this patient that most important thing will be to tackle when you are managing the patient?
Sir, inhalational burn injury will be the most important factor to evaluate.
Okay. 2 marks.
Team 3, sir.
Team 3. By seeing the area of the burns, can you assess that it might be 3rd-degree burn also? And how will you assess that?
Third degree would be only if later on they can tell.
There will be parchment, like the lack of blood supply in the subcutaneous tissue will be reflected, sir. It will be like parchment and it might go into gangrene.
And if we pinprick, then bleed won't be
Bleed
there at
also
that
won't be
side.
there.
So if only whole of the skin is involved, you will not say like that. Team 4.
So there will be third degree.
I am asking about this particular patient. Can you assess any 3rd-degree burn in this patient?
Yes, sir. On clinical examination, we can see there are areas of leathery white color and over the chest area and over the arms and neck region. So those areas appear to be the 3rd-degree burns. The chest, the neck, and the aspect visible over the arm and on the left forearm.
Not on the phone exactly, but okay. Team 3 or 4? You were team 4.
Four, sir.
So
Four,
1
1
mark.
mark.
1 mark. Now it is turn of team 3. Any other people will ask?
Can I ask a question?
The patrons also can
Yeah.
ask, or panelists
Yes.
also can ask. Yeah, Shailesh?
So, during the tangential action of the burns, which are the classical precautions which are followed, we say with the rule of 2 or rule of 20. So, any idea about what we follow regarding tangential action of burns with any figure related to 2?
Ma'am, you have to tell which team this question will be directed to.
It's
Team
team
3.
3.
Team 3.
Tangential action of burns when we do.
Sir, we have to, there is a rule of 2 or 20. 2 pints of blood has to be reserved.
Yes.
It has to be done within 24 hours to 2 days. And the the procedure should not go more than 2 hours.
Yes.
And 20%, more than 20% should not be tangentially excised at one
Yes.
sitting.
I think they
And
should
ICU setup should be there.
they should get the marks.
2 marks
Okay.
to team
Yes.
3. Team 4?
Team 4, what precautions will you take when you are doing a tangential excision of the burns to prevent blood loss?
Team
So
4. Team 4?
Yes, sir. We'll first create a tumescent. We'll do the tumescent infiltration using ADR, bupivacaine, and NS, so that
Will you specify what will you use?
so we can use 20 ml of bupivacaine along with with 2 pints of 2 ampules of ADR and into 100 ml of NS, sir. And then we'll infiltrate it around the area which we are going to perform the tangential excision on, and that will prevent some amount of blood loss which would have happened if we wouldn't have infiltrated. So it will control the bleeding in that region.
What is the advantages of using tourniquet? Advantages and disadvantages.
Is it?
Using a
No,
tourniquet.
only one question,
Okay. This is
Shailesh.
one question. Okay, correct.
Now
So they
to
will get
second team, third.
mark.
fourth, fifth.
Team 5?
How much marks he would
2
like to
marks,
give?
sir.
2 marks.
Yes.
Now team 5.
Team 5. What are the advantages and disadvantages of using a tourniquet while doing tangential excision?
If you use the tourniquet, sir, following tangential excision, we won't be able to identify the pinpoint bleeding. So we cannot assess the excision depth. Adequacy of the excision depth is correct or not. And advantage is
Less amount of blood.
Loss will occur, sir.
Okay.
2 marks?
Yes.
Team 6? You would like to ask, or anyone else?
Question for team 6. Who
Yeah.
described tangential excision? Venugopal.
Zorovic,
sir.
sorry.
Who
So it was
described?
Zorovic.
Zorovic, no. You are near.
Sir.
You are combining names and surnames. So 0 marks for team 6.
Any other team?
No,
One.
but it should be passed on.
Now passed
other
on to
team.
one.
Team
Team
1.
1.
Okay.
Zora Janzikovic.
Yeah, it's Zora Zankovic.
So 1 mark.
Okay. Okay, ma'am.
Sir,
We'll move to the
Srikant
next
sir,
button.
sir.
So this patient
to
is
be
of this patient is most probably of self-immolation. Sorry, but rarely it may be homicidal also. People may get poured and then after that put on fire, but mostly it is suicidal burn. And in suicidal burn, you will see from the injury from upside down. not from down to upwards, which is usually in accidental and homicidal burns. Usually these are deep burns, and the face, neck, chest, upper body parts are involved. Neck is, in this case, is quite a lot deep burn, and you have to see the inhalational burn, and you have to manage the inhalational burn on priority, because later on there will be edema within 8 hours to 12 hours, and then it will be difficult for intubation also. So it's better in such cases that you intubate the patient. And as early as possible, once the patient is hemodynamically stable, you should go for tangential excision if facilities are available and blood is available. Otherwise, you can treat it conservatively. If circumferential burn is there, which is most probably on this left forearm, then you have to go for fasciotomy.
Sclerotomy.
Okay. Sclerotomy or fasciotomy, whatever is free. Okay. Anything else anybody would like to add? Because I have already asked questions.
Yes, sir. Most of them covered. So we'll go to the second spotter, sir. Time is also over.
Can I ask a question there?
Sir. Second.
Just one short question.
Okay, sir.
Is this person is a right-handed dominant person or a left-handed?
Right-handed.
Right-handed.
No
If
marks.
whatever hand, right and left, there are two only. You have to say why.
He's
If he is right, why? If it is left, why?
He's a right dominant person, sir.
Why so?
Because he must have poured the inflammable liquid with his right hand and then lit himself on fire. So therefore, there are more burns on the left side of the body than compared to the right side.
Yes, yes. There are more burn on the left side in continuity. Okay.
Ma'am, can I
Spotter
move?
2.
I would like to
Team 2
request.
introduce Cheskum.
Yes.
Yes, so I'll take
Team
over.
2.
Team 2, please introduce yourself.
Introduce
The
yourself
panelists.
first.
Sponsor, sir.
Hello, sir. I am Dr. Smith from KEM Hospital, and
Myself, Dr. Girija. We both are third year residents from SHGS and KEM Hospital, Mumbai. Sir. Good evening, everyone.
So, welcome Team KEM. So this is a 8-year-old child who presented with this perineal contracture 2 years after the actual burn injury or insult. So please be specific and to the point in your answers. Give us 4 to 5 complaints which this patient might have.
So patient will have difficulty in walking, difficulty in ambulation or walking, and patient will have difficulty in urination and also the difficulty in sitting,
passing stool, difficulty in passing stool. Then
patient might have itching also, the patient, because of the burn scar hypertrophy. I can see some scratch marks and desquamation all around the scar tissue.
Okay, that's fine. What would be your reconstructive procedure of choice for this patient?
So second question for them.
Second question for team 1.
Team 2, sir.
Sorry, team 2.
Sir, I would like to go for incisional release of the post-burn contracture, and I would like to go for resurfacing with split thickness skin graft, sir.
Okay. Okay. Next, 4 marks for team 2. Question for team 3, I believe. Yeah. Is team 3 over here?
Yes, sir.
Yeah. So question for team 3, if this patient would have presented to you in acute, at the time of acute injury, how would you prevent this contracture?
Sir, we would prevent by first positioning the child properly. First thing would be the positioning. Second thing would be proper dressing and wound care.
Positioning.
And all,
Details of positioning we want, na?
Sir, we in supine position with the hips abducted and a spacer in between, and splint also to prevent adduction of the hips, sir.
Sir, we basically take care of the dressing. The dressing should separate both the legs at the region of the perineum, and regular massaging after the secondary healing of the wound should be done. And better would be if we could take the patient for early tangential excision and grafting, if possible.
So if you were to flap this particular defect after resurfacing, give us 4 to 5 flap options which you would like to consider.
The first question is answered.
First question is answered.
2 marks.
Yeah, first question is answered. Second question for team 3.
Sir, the anterior perineal one is more of a linear band kind of contracture, sir. So for that, we can go for local tissue rearrangements like Z-plasty, multiple Z-plasties in series, or a jumping man Z-plasty, and any local flaps, sir. The posterior one near the perianal region looks like more of a broader contracture band, which might require SSD after release, after excision.
The question is very specific. Name 4 to 5 local flap options after release of this contracture if a defect is created.
Sir, Z-plasties, modifications of Z-plasty, and
So circular advancement flap for the rotational advancement for the buttocks, sir, buttock region, and
we can go for transposition flap from the medial aspect of the thigh, sir.
Okay, 2 marks for team 3 for both the questions combined together. Now for team 4, the yes, ma'am.
2 second question answer 1 mark you are giving?
No, 0 marks.
0. Okay. So team 4 can answer the same question. The flaps, past question.
So we can do a
The
pedicled,
flaps.
pedicled ALT,
Yes.
pedicled DEP,
Yes.
gracilis
Yes.
muscle flap with the skin graft.
The Singapore flap.
Singapore,
Yes.
internal
Internal
pudendal
pudendal
artery
artery
based
based
flap.
flap.
Okay, 2 marks for past
No,
question. So 1
One
mark.
mark. 1 mark.
Now direct question to team 4.
Yeah, direct question to team 4. If you were to do a flap for this particular defect, what are the advantages? Name 2 advantages of a flap over skin graft for this defect in this particular child.
The splintage requirement will be reduced, sir, post flap,
Okay.
and the chances of recontracture will be lessened with a flap.
That is almost the same, I believe. One more.
It will give a better contour in that region. Better.
It will be bulkier, no?
But in that region, we would require that excess tissue to be present.
Anything more? It is a child. It will grow with age.
It will grow with age.
So second question for you is, if the patient would have presented to you acutely, what would have been the degree of burns at that point of time? What do you think?
It would be deep burn, sir. Second
More
degree,
specific,
third
deep or
burns.
third degree.
Second degree, deep or third degree.
Yes,
so yes, 4 marks to team 4.
3 marks, sir. Passed on. Passed on is what? No, passed on is 1 mark, and primary question is 2 marks. So 3 marks. 2 marks.
Yes, madam. 2 questions. So total 5 marks.
Yes. Yes.
Okay, sir.
Team
Team 5.
4 will get 5
Get
marks.
5
for
marks.
this question.
Okay.
Yes.
Okay. Okay.
Right. So this question is for team 5 now.
5.
First
Yes.
primary question for team 5. So if we are going to do an incisional release, we would like to do fish tails at the end of the release. What is the reason for those fish tails? 2 reasons.
So, if you're planning to do an incisional release and graft the patient, sir, the fishtailing is done to prevent contracture again after grafting, sir, and the basically addition again at the ends to form a recontracture, basically. And so the second thing, it increases the surface area for grafting, sir, so we can give a bigger graft to the patient.
Good. Second question for you is, if this patient would have presented at, say, maybe around 3 to 6 months with this contracture, so it is an immature contracture at that point of time, what would you do at that point of time? Would you release it? Would you wait, and why?
So if it is an immature contracture, so we can wait. And so we can also give a trial of CO2 laser to the patient, sir, and other modalities of treatment, sir. We can give massage, we can give compression garment, and so splinting, early splintage would be good, sir. At the site of acute burns, serial splinting, during the time of acute burns.
At 3 to 6 months, the contracture is established. It is no more acute.
So compression garment, regular massage, sir, and we can go ahead with the CO2 laser at that point of time.
So question passes to next team.
Team 6.
Team 6, can you answer?
Yes, sir. This,
Immature contracture, same clinical
sir,
presentation.
yes, sir. If the area is small, we can plan for excision and grafting. If like in the vital areas, we can in the perineal area, we can plan for excision grafting, sir.
So yes, even if it is an immature contracture, it is significantly limiting the functions. So we should intervene, even if it is an immature contracture, right? So 1 mark, passed on 1 mark to team 6 and 2 marks to team 5.
Yes. Team 6 questions, sir. 2 questions for team 6. Next.
Yeah, direct question to team 6, first question. So you have operated this patient for incisional release and grafting. What would be your post-op protocol?
The post-op protocol, like first and foremost, is since the perineal area, there's a high chance of soiling of the graft. So to prevent infection, catheterization of the patient and
regular dressings have to be followed, and also adequate splintage of the area with hip abducted and externally rotated.
And we can also consider the diversion colostomy also in this, like since it's a child with the high chances of getting soiled. So it's the rare, like it's not the last option. So like.
Anything more you want to add?
Yeah, like I prefer to go with flap rather than the graft in this region, sir.
Okay, second question for team 6 is this patient complains of severe itching. How would you address itching for this patient?
The first and foremost is moisturizer application, scar massaging, then silicone sheet dressings can be used, or antihistamines can be provided in the later, and then even even the lasers can be used. Lasers can be used. CO2 lasers.
Okay, total 3 marks for team 6 for 2 questions combined.
Okay, sir.
Anything you want to pass on to the team 1?
No.
To answer better?
I think they have answered it partly. The thing which they haven't answered is mainly
Let them,
pressure garments.
Yes, sir, pressure garment.
Team
Okay.
1, team 1 might have answered.
They answered it partly, so it would have been difficult to give marks even after passing it on. So I
1-1,
thought.
sir.
That's
1-1.
low, I thought.
We can give 1-1.
Yeah.
Okay. Now direct questions to team 1.
Yeah, direct question to team 1. If you see, there is post-burns hypopigmentation over the right thigh or some areas. How do you address this post-burns hypopigmented patches? What are the options you have? Give us 4 to 5 options.
So hypopigmentation, I would like to first option is excision of that area and resurfacing using skin graft.
Okay.
Dermabrasion followed by thin split thickness graft. Then we can use melanocyte transfer, non-cultured keratinocyte melanocyte transfer, or outer root sheath cell melanocyte transfer.
Okay. Anything else? Anything non-surgical you would like to add?
Tattooing, sir.
Exactly. Tattooing, camouflaging. These are options. Definitely these are options, right? So second direct question to team 1 is, if this patient would have been an adult male instead of a young child, any changes in your plan, decision-making plan? If you would have considered for this child versus adult?
In child, we would prefer split thickness skin graft, whereas in adult, we would prefer split thickness skin graft.
And why is that?
Also, split thickness skin graft, it does not grow with the age of the child, while flap it does. So for a child, it would be more advantageous to use a flap.
Second reason? Pass on to the next team. Yes, you want to say?
To prevent chances of recontracture.
That you have already covered it. Anything more specific?
Sir,
Child versus adult?
Sir, child would be in case of adult will comply with the post-operative protocols for splintage and pressure
Yes.
garment and exercise, where child will not be comply for the post-op protocols.
Right. Compliance of the child is going to be difficult. Splintage for prolonged duration is going to be difficult. So direct marks for team 1 are 3 and passed on
Passed
mark
1.
for team
2.
2
Team
is
2.
1.
No, sir. Team 2 gets a passed on mark.
Yeah.
And team 1 gets 3 marks for direct questions.
Right, ma'am.
Yes. So we completed the total 6 teams.
Yes.
And now the judges or panelists will ask one question to each team. You have completed the questions.
Yes, sir. Yes, ma'am.
Thank you.
Yeah, so there's hello
Sanjeev, sir.
everyone. Let us go for the basic question first. Can you, the team 1?
Team 2, sir.
Team 2, team 2.
Team 2. So how do you define a contracture and what is the kind of, how is it formed and what are the various histological or histopathological, you can say the contents or the structures in the contracture?
So contracture will usually formed if it is more deeper burns, like deep dermal or full thickness burns.
Definition of contracture. What is the definition of contracture?
Only definition.
Only definition.
Non-physiological healing, which with limitation of with functional limitation and the hypertrophy of the wound, hypertrophy of the area is defined as contracture.
Can we pass on to the next team? See their answer.
Team 3.
Sequelae of wound healing is contraction, and if it forms a deformity, it is called a contracture across a joint, mainly across a joint.
Fine.
Wound contraction resulting in a deformity across a joint.
Can you use something like it's a dynamic or permanent or contraction of it?
Can move to the other teams.
So it is a
Permanent
deformity.
Fine. So next question.
Sir, are you satisfied or it has to be improved by other team?
We can go for another team.
Yeah,
team
yes.
4.
Team 4.
Sir, contracture is the end product of the process of contraction over prolonged.
So I think we can go with the team 3 and give them 1 mark.
Team 3 answered better, so they'll get 1 mark, isn't it, sir?
Right. So
Yeah.
next, I think anybody else can ask questions to the next teams.
Direct question to team 3.
Somebody else is asking.
Bhattacharya, sir.
Yes, see, this is a contracture involving anterior surface as well as posterior surface. Okay, that means near the anal region also. So, which one will you release first? Anteriorly, you will start releasing, or you will release posteriorly first?
Sir, we'll release anteriorly first because that is a major contracture which is pulling and causing the both the legs to be together.
Degree of
causing
contracture is higher in the anterior. So functionally, it will be beneficial for him.
In
First.
continuity, which side first, right side or left side? And why?
The right side.
Why?
Right side will give him more benefit.
See, both sides are contracted. Right side is more.
Yes, yes,
yes, sir.
So, but why right side? Any other reason?
So to prevent adduction contracture of the hip on the right
Anyway,
side.
you are going to release it. You have to release completely. Why right side first?
Because the degree of contracture is high, even
That
the
you have
joint,
said. That you have
joint
said.
might be affected.
Any other reason?
While walking, there might be that
the gait will be better.
Next thing.
So the right side is more extensive. The left side you can only see it is extending up to the mid point of the burned area. The scarring is extending only till the mid aspect of the thigh. It is more extensive towards the right side. If you're releasing the right side, we'll get a better release. The patient will be able to walk better. More extensive it is.
Patient will walk if adequately done on both sides as well as perineum. Okay. Anything can hold from that. Any other reason?
Sir, can I try?
Yeah.
The skin which is getting pulled on the right side, it is also covering the urinary region.
Yes.
So when we release, so it will also the space will also be there for patient to pass urine properly.
Yes. Yes. That
So
is the
they
correct
get
answer.
2 marks.
2 marks for team
And
3.
and
Team 4.
and therefore,
Team 4, sir.
how will you prevent urethral injury while releasing this contracture?
So we should give
The
a
team
proper
4, sir.
We'll
Foley should be
place a Foley's catheter, sir, and then
But see, the phallus is embedded almost into the contracture. When will you put the Foley's?
we'll
You
release
can't
it
see the phallus.
partially. First, after releasing partially, we can.
Once we visualize the phallus,
We'll first catheterize and then we'll proceed with the complete release.
Therefore, where will you initiate release?
At the zenith of the contracture,
on
which is
the right side.
At the
Zenith of the contracture, sir, on the right side, which is towards the right side.
which part of contracture will you start releasing to prevent urethral injury?
just above the connection between the both sides, the point which is
Towards the right.
Bolo.
There's a part.
Any other next team? Yeah.
So the point of maximum tension is the place where we need to start releasing first, sir. That is exactly at the junction of the labia majora, sir, anteriorly. 12 o'clock position. That is where we should start releasing first.
And in which direction it will go? Your knife move?
So it has to go downwards, sir, from 12 o'clock to 11 o'clock. Basically anti-clockwise direction, sir, it would go.
Then how will you prevent the urethral injury?
So after placing the first incision, sir, we would try and catheterize the patient, sir, and then progress with the remaining release.
See, catheterization will only be possible when you find the urethra.
Yes, sir.
So from 6 o'clock to 12 o'clock, we should go
away
from the region of the embedded penis phallus.
Any other team?
Team 6.
See, you all are talking about the clock, but you are not moving the clock properly. That's the thing.
Team 6.
Yes.
From 11 o'clock position till to the 6 o'clock position, sir, in that direction.
Clockwise, anti-clockwise.
Sir, it's anti-clockwise, sir.
Then how can you prevent the urethral injury?
So we
see, you have to identify the urethra at the earliest while releasing the injury. When you are going away from the urethra, how you are going to identify the urethral passage? You have to put the catheter at the earliest.
Team 1 or 2, anybody would like to answer?
We would like to go clockwise from 12 o'clock to 6 o'clock on left side. Then identify the urethra, first catheterize, then release the remaining contracture.
5 o'clock to 6 o'clock means?
12 o'clock to 6 o'clock.
12 o'clock to 6 o'clock.
On
Clockwise,
left side,
anti-clockwise.
clockwise.
Correct.
Correct, sir.
Correct.
So team
Okay.
1 get the
1 mark. 1 mark.
1 mark.
Will you require a change of posture?
This is for team 5.
5.
Direct question to team 5.
तो AED के release करो की करे urethra you'll get clockwise and
In which position you will start operating? Are you going to operate simultaneously the whole contracture, anteriorly as well as posteriorly? First question is that.
So we'll keep the patient in lithotomy position itself, sir, and we would start anteriorly.
Will you be able to put this patient in lithotomy with so much of contraction?
No, the patient already has a contracture, sir. So we will not be able to abduct the thigh any further. So we will have to take the patient in the supine position with the contracture, release it, and then we can proceed with the positioning, sir.
So first will you release what?
So the anterior contracture first, sir.
Anterior contracture. And then you would like to put it in lithotomy position.
So it won't be possible completely, sir. But then
See,
the
lithotomy position, there is nothing like incomplete lithotomy, isn't it?
Yeah.
When you say lithotomy, it is a definitive procedure
in
using
supine
certain
position,
things.
sir. In supine position, we'll have to start releasing the contracture, sir.
Then you have released the contracture in supine position, the anterior contracture on both sides.
So the posterior contracture we will not release in the same seating, sir. We will plan it at a separate date for the patient.
But will it next team?
In the first setting, we'll go with anterior contracture release, sir, followed by skin resurfacing, and then later on we'll change the patient position to prone, and then we can plan for the posterior release.
So what is the immediate post-op splinting you are advising?
Hip in abduction and external rotation.
So if the perineal contracture remains in continuity, will it allow abduction of both the thighs?
No, sir. This post release and post resurfacing with the STSG. Once the contracture is entirely released, then we can provide a post-op splintage.
But the posterior contracture is continuing. No, you are not releasing. You are telling only anterior. So what will happen?
We can lift the patient, then
yes.
We can change the position after releasing the anterior contractures.
And do what?
Like
release the contracture in the prone position for the posterior one.
Posterior one. And then what will you do?
We'll do the skin resurfacing with the skin.
Okay, done. Then
splintage.
Then splinting. So the earlier team was telling only anterior, only one side. You are telling both sides. Antero-posterior. Complete release.
Yes.
Correct.
So 1 mark to team 6, sir?
Yes.
Okay.
So direct question to team 5.
Again, coming to urethral protection of urethra. You have put the catheter. Still, it is buried within the contracture. Okay. So, how will you protect the urethra while doing the dissection? What precaution will you take? Very practical, technical thing I'm asking. With great difficulty, you could visualize the urethra, you could pass the catheter. Then what? How do you prevent? It's a male patient, so long urethra.
This question is for team 5 or team 6, sir?
Beg your pardon?
Question is for team 5 or team 6, sir?
Team 6, team 5 passed, you answered. So you got
sir.
1 mark. Team 6 direct question this is.
Direct question.
So, since in this patient, like in the contract, we can delineate the skin of the penis by the change of skin architecture. So that is the landmark which that anatomical landmark will see while incising, sir. Then we'll go after. We'll avoid using electrocautery.
See, the question is that the phallus is deeply buried into the scar. You could see the urethral opening. You have passed a catheter with difficulty. Fine, with some maneuver. Then, while dissecting it further, you have to release the phallus also from the fibrous tissue. So, how will you proceed? How will you prevent urethral injury?
We'll give a traction with a Foley's catheter towards the front of the phallus, sir. And
Foley's
then,
catheter does not give you much traction because even your assistant, because it is buried. How much traction you are going to give? What will be the exact technical thing which you will use? Your Caesar is with you. Your forceps is with you.
We can pass an artery under above anteriorly
In which
over the phallus,
direction will
and
you?
then we'll place the skin.
In which direction will you dissect? Let me put it straight.
sir, we'll start from we'll go posteriorly, sir, towards the 6 o'clock position where the natural course of urethra is there. In that direction we'll go. Once we reach the perineal region, we'll stop it, sir.
Next team.
We would like to perform the dissection away from the urethra.
Away from the urethra.
Yes.
Yes. So how will you identify the plane? That's correct. How will you identify the plane away from the urethra? Otherwise, you will cut the urethra. Disaster. Absolutely practical on the table, I'm asking. Any other team?
Check the dye. We can insert
Yes.
dye and we
Sir, we put
dye. We'll see. We'll dissect away from the urethral region.
You will go centrifugally. That means away from the urethra, dissecting laterally. But even then, you do not know where is the phallus lying, isn't it? You just pass the catheter. So that catheter will guide you. How will that catheter in the urethra will guide you?
Sir, we
palpate it.
Pull the catheter. We pull
By
the
palpating the catheter, we'll be able to know where it lies.
Beg your pardon?
We'll palpate the catheter, sir, and keep our finger over it and then dissect away from it.
That's the correct thing. You will keep your finger on the urethra. That means on the catheter. You will keep on feeling. The urethra should be within your index finger and thumb.
Hold.
Okay.
Hold.
And the dictum is you cut your finger before cutting the urethra.
Yeah.
Okay. So that is the dictum. So
Sir, direct question to
okay.
team 1, sir.
To team 1 is
direct question.
Direct question. Suppose you have to design a flap to prevent secondary contracture. How will you design this flap? On the right side, because that side is more contracted. If you have to give a flap cover in certain vital area of after release, how will you decide it? What flap will you design?
Team 2?
Sir, we'll plan for the posterior thigh flap on the right side, besides the after releasing the contracture.
How far will it reach anteriorly?
Near the upper margin of the like till the pubic.
Do you want to resurface the whole post-release defect with a flap or something else?
So in medial most part, medial and upper medial thigh part, which has extensive scarring, we'll do the flap cover, and laterally we can resurface with a grafting, sir, STSG.
Any other reason of giving a flap there?
Surrounding
Because
the
of
surrounding the perineal and the like vaginal or phallus area, we give a flap so that further next like secondary contracture will not occur, and patient can keep the limb in abducted position as well.
And that area is mobile area, sir. There's high chance of recontracture, and also the graft secondary graft breakdown will be more.
See, there are two reasons for giving a flap cover in a post-release, post-contracture release. In this case, I'm talking about. So what are those two areas where would you like to give a flap cover and why?
We would like to add that sir, we would want to, if the femoral vessels are exposed, then we would like to give a flap cover in that area.
So you have to keep in mind the vital structures underneath and what is going to be exposed. These are very deep contracture. So one is femoral.
Direct question to team 2, sir.
Yes.
Madam, direct question to team 2. We are done, ma'am.
Done, na?
Done, ma'am.
Now they are done.
No, this is
No,
spotted
what is
2.
the mark,
So,
sir?
okay.
One mark.
Team 1
One-
will you?
one
One
mark.
mark for team 2 passed
Yeah.
question. Right.
Okay.
Now, Sanjeev Uppal, sir, you'd like to tell anything? Final remarks? Or we'll go to spotter 3?
No, all the teams attempted well, but there's one thing which I think we could not ask in detail is about once the patient comes, such kind of patient comes with burns in the ward. So what is the primary? They answered a bit, but not exactly that. What should we do at that very time so that these kind of contractures do not develop? So the prevention part. Just a comment. They should learn about that. And the rest, I think, very well explained and asked by Dr. Bhattacharya about the basics of the surgery. The vital structures need to be taken care of, and how do we go about that? Of course, these kind of contractions may not be very, very common, and maybe any institute will deal 2 or 3 cases in the tenure of 3 years or 4 years, 3-year tenure of a resident. So I think this is a very important case as such. Yeah. Thank you.
Thank you, sir.
Now we'll move to the third spotter. I would like to request Durga ma'am to start questioning and team 3 to introduce yourself to the panelists.
Good afternoon, sir. I'm Dr. Kanak Gupta from JIPMER, second year resident, plastic surgery.
Good afternoon, sir. I'm Dr. Priya, second year MCH resident.
Madam, you can proceed, ma'am.
Yeah. Good evening, everyone. This gentleman is 25 years old male. He is traveling in a truck and standing on the back side, so he sustained injuries. Can you just tell me the diagnosis of this patient?
Ma'am, this is a deep, full thickness burns, most probably due to etiology electrical, involving the right side of the neck and the and the lobule and the pinna of the right ear.
Team 4, can you
Ma'am, 2 questions to team 3.
Okay.
So,
this question
mark
is
for
incomplete.
the question 1.
So I'll pass to the next for this question because this is not complete.
Okay.
They have just tell the complaints and not it's a diagnosis. Team 4, can you make it better?
Full thickness electrical burns involving the right side of the neck and the lower 2/3 of the right ear.
Team 5, can you make it 5?
Ma'am, this is it can be chemical burn as well, ma'am. Involving the lobule, ear lobule.
Team 6.
Complete.
If the full thickness burns over the right side of the neck and the right ear, exposing them it's a 4th degree burns, even exposing the muscles.
Yeah, a little bit better this one. It's a high voltage. You have to tell it's a low voltage or a high voltage electric contact burn. Okay, with pinna on the right side of the neck, pinna, and with exposed muscle, 4 degrees. That is okay, but slightly, you have not mentioned low voltage, high voltage. It should be very clear. Diagnosis should be diagnosis. Okay, 1 point for this team. Now team 3.
Which team you are giving, ma'am?
6.
6, ma'am. Team 6.
6. But team 4 told electrical burns.
Yeah.
Team 3 also
Remaining
told.
all told that it is a 3rd degree burns.
But it's, diagnosis is not clear, Yeah, 1 we can give it to team 3 because everybody has done the same to team 3 because it is a
So,
primary.
a direct question to team 3. So, 1
Yeah,
mark to
second
the team
one.
3
Yeah.
and 1 mark to
6.
Team 6.
team 6.
Yeah.
Okay.
Team 3, next question. 3 important issues to be addressed when he will reach in York casualty 2 hours after the burns. Just enumerate what are the 3 important issues and how you will treat in short.
As soon as the patient comes to emergency, we have to go by the protocol of airway breathing and circulation and secure these 3 things first. And when coming to electrical burns in particular, we'll have to take care of the cardiac issue also, take a ECG and rule out any arrhythmias. And also we'll have to, it is because...
What type of arrhythmias?
The most common is sinus tachycardia, but the fatal can be atrial fibrillation and ventricular fibrillation.
Which is
that
common?
should be kid.
Which is common? Which is
commonest is sinus tachycardia, but the commonest one causing death is fibrillation.
No, I'm saying which is common. I'm not asking which is the common cause of death. Which is the commonest cause of arrhythmia?
Sinus tachycardia is the commonest one.
Atrial fibrillation. And third one is what important? First is the
third
EKG.
one, rhabdomyolysis can happen, and we'll have to prevent acute renal failure. So we have to start the resuscitation as soon as possible. And
seeing the area involved, we have to.
I'm saying 3 important issues and what EKG. This is okay, cardiac. Now you tell me in short. It's a quiz. It's not a long question answer. Like fluid, what you will do, and how you will give, how much you will give. Just precise.
Because it is the electrical burns, we will go by modified Parklet's giving 7 ml per kg per TBSA, and the first half in first 8 hours, and then second half in the next 16 hours. It will be 7 ml, and we'll have to maintain the urine output nearly 3 ml per kg per hour. 2 to 3 ml per kg per hour.
Yeah, it's about 2 ml, not 3 ml. And third point. 1 is EKG, 1 is fluid resuscitation. Third important this patient is.
And
third important. Initially you have described everything. I'm asking about this patient. 3 important. 2 are fluid resuscitation, electric burn with this, and EKG. And third one important is.
And
hearing the loss.
Neck. It is a full thickness burn involving the lateral aspect of the neck, which might expose the vital structures.
That is okay. During the resuscitation, I'm asking what important take care you will take. That is the later things. For what important structure, which will we have to deal in emergency. There are so many vital structures.
From the neck, carotid blowout, we'll have to.
Next team.
The jugular vein and the carotid artery, ma'am.
No, that is not the primary concern. When the patient comes to you.
Team 5.
This electrolyte, ma'am.
Rhabdomyolysis, ma'am.
Team 6.
Rhabdomyolysis and dyslipidemia.
Team 6.
Ma'am, head injury, ma'am. Like involvement
Team
of the
7.
brain.
Team 7 patient is sitting, you know. That is okay. That is that is for all patients.
Team 1.
Team 1.
Myoglobinuria blocking the renal
Already
they told. They told that. Team 2.
And neurovascular structure.
No, it's a airway which is very important. Airway which is very important because it is almost on the lateral over the trachea and the anteriorly also. So we have to, because there will be edema and everything, it's a contact burn. Okay, very important. It's the first one to be taken care, first airway, then we will go for resuscitation and we have to assess the airway. Now question for team.
question. 1 mark you want to give or 2 marks? Out of 3, they answered 2. And initial resuscitation, they told this. They didn't tell. So you want to give 2 or 1?
2 marks.
2 marks. To team 3. Now direct question to team 4.
You know, if you see a dark color urine, then what is your diagnosis and what complication it will cause and how?
It can be rhabdomyolysis, ma'am. Myoglobinuria. So the second part of the question was, ma'am?
What complication it will cause and how?
It can cause renal failure, ma'am. Usually acute tubular injury and renal failure, acute kidney injury.
How?
So around 100 gram of 100 gram of
How it will cause the renal failure?
When there is a electrical injury, the muscle is damaged by the Z.
Myoglobin cause renal failure.
When the bands of the sarcomere gets damaged, the calcium inside the muscle will.
Team 4. It's I think team 4.
Team 4. Team 5. You want to pass on to team 5?
Yeah, pass on.
Team 5.
Ma'am, the myoglobin that will be released from the damaged muscles will cause acute tubular necrosis in the renal tubule.
How it will cause?
It is a pigment, ma'am. It will get deposited in the renal tubules, and
it is if it is deposited, then how during the treatment it flush out from the, when we do various type of maneuver or a resuscitation, how it's deposited? It is in the dissolved form. How it is deposited? Next team.
Team 6.
Ma'am, it is not filtered by the renal tubules. It gets accumulated there.
It never goes to the tubules. It remains in the.
There are macromolecules which will not be filtered easily, so they get accumulated and causing.
Next team. 1.
Blocks the renal tubules, ma'am.
It
blocks the renal tubules.
I'm saying how it blocks and when the treatment and how they flushed away. That is the main concern.
Then myoglobin globules will block the renal tubule, and then there will be backflow of the urine. So increase.
Next team. Finish or हो गए? Everybody.
Team 3.
The myoglobin, which is a bigger molecule, it doesn't get filtered and it causes tubular necrosis, tubular epithelial cells necrosis.
No, this is all team. I think finished.
Yeah.
Yes, madam.
Yes, madam.
What happens is that it combines with the protein and form the cast. So it is in combined form. When we give various resuscitation, that keep this myoglobin in the dissolved state, so it flush out. Okay. The cast which deposited. Now the question for team, which team?
5. Direct question to team 5.
Fine. Yeah. What are the important concern in this type of electric?
No. Team 4 will get to one more question, madam.
Second question for team
Second
4.
question for team 4.
Fine. How we will treat this condition?
First, we'll after securing the airway and maintaining the breathing and circulation.
I'm saying, I asked you red or this color dark red
Myoglobin.
is diagnosis. Now, how you will treat this condition?
First is we'll give 4 ml per kg per body surface area fluid. We'll give more amount of fluids, and we'll supplement it with mannitol. We can either give mannitol and also soda bicarb.
How much?
25 mg of mannitol in the initial 6 hours, ma'am.
It's a fix, not related with some fixed one. And how much soda bicarb?
Soda bicarb 50
It's also
milliliters.
fixed. Next team.
80 to 100 ml of soda, 8.4% soda bicarbonate, ma'am. We'll give as a continuous infusion of 80 to 100 ml.
No, it's
80 to
the ml or some milliequivalents or something like that.
8.4 milliequivalents.
8.4 milliequivalents of
I mean, other than soda bicarb, your option.
we'll give mannitol, ma'am. 25 gram we'll give as a loading dose, and
And?
followed by 12.5 gram we will give as
Measures next.
yes, ma'am.
Yes,
25 milligram.
Mannitol and
ma'am, RL, the ringer tape, ma'am. The initial resuscitation with the fluid.
how much I'm saying, just precise.
Ma'am, we have to monitor the urine output of the patient, ma'am. So the urine output should be around 2 ml per kg per hour, ma'am, for an adult patient.
This is partially correct, carry on question. Partially correct. Because unit, this third, they said RL 4 ml per kg. It's not a fixed, for any burn. You cannot give 4 ml per kg. In spite of that, urine is 300 ml, 400. You should, with this fluid, you have to monitor at least 2 ml per kg. It is not the fixed formula. You will give 7 ml, 9 ml, 8 ml, But the answer of this question, soda bicarb, everybody, they won't be able to tell. It's per kg, 1 to 2 milliequivalent per kg. Maybe you are giving for the adult, you are telling ki 50, 80 ml de denge, but not for the, child or a, less kg weight. So this is not correct. We will give the 80 ml of milliequivalent or 2 ampules or something like that, 100 ml. It is not fixed. 1 to 2 ml milliequivalent per kg. Madam, how much to give? Because carry on is also partial.
We haven't passed on to the other teams also. So you're not happy with the answer. We'll just don't give marks to anyone.
Then one question for team 3 for main questions.
Team 5.
But team 4
two
has
questions
answered, but
you have.
not
Team
both.
4, only one marks is to be given.
One
mark.
One you
Okay.
asked myoglobinuria, and the
Only
team.
for that is the diagnosis was correct, but the treatment was not correct.
So you want to give 2 marks for the team 4 diagnosis?
Diagnosis is for 1 mark, 2 marks. Yeah, 2 marks.
2
So,
marks and
yeah.
no marks for the second question.
No.
So team 5 direct questions.
Yeah, direct questions. What are the important concern in this type of patient with the electric burn? Now tell me what are the major concern because of the location and all these things of this patient.
In this patient, ma'am, because of the location of the burn, one is that the major structures can get affected. That is, a carotid blowout can occur, ma'am, and jugular vein thrombosis can occur, ma'am. Along with that, there is burns over the right ear, and chondritis can occur, ma'am, to the right ear. If acute perichondritis can occur, ma'am, to the right ear.
Also laryngeal edema.
Laryngeal edema can occur, ma'am, because of the as the burn is near to the trachea, and it can cause.
Also, ma'am, nerve injury, brachial plexus. Brachial plexus affection is also possible.
Anything more?
Ma'am, the muscles, sternocleidomastoid is already exposed, and ma'am, that can get necrosed.
The spinal accessory nerve can also get involved, ma'am.
That is the breakup. Okay, it's all right. There is one more, that is the cervical vertebrae. We should take care of that also. Okay, 2 marks for this team. Now, second question is, which tissue has the least resistance to electric burns? So whether damage will be less or more? Skin, nerve, vessels, and muscles.
Least resistance is given by the nerves, ma'am. So the electric current flows better through the nerves, and then it's the muscles that is the least resistant, and the skin is the most resistant.
I'm saying which is tissue has the least resistance and whether the damage will be less or more. Give the complete answer.
If the nerve is the less resistance, and the damage will be less. If the resistance is more, then the damage will be more.
Okay, correct answer. 4 number for this team. Team 6. What are the 3 different, we can say, a mechanism of sustaining electrical burn injury?
One is direct burns, then it's arc burns, and flash burns. Yes, one was a flash burn.
Yeah, correct. Then second question is, how you will manage the wound when the patient comes to you 2 hours after the burn injury? Now everything was there. Resuscitation has done, everything has done. How you will manage this?
Since it's the full thickness burns, and we want to know about the status of the vessels also, and once the patient is stabilized, I'll take it for facial excision of the wound and the immediate resurfacing with the flap cover, ma'am, to safeguard the vital structures.
Next team. Next team.
Team 1. Team 1.
I would like to initially remove the SR and look for and do the debridement, and for here also I would advise for no pressure.
Next.
Team 2.
Ma'am, I would like to go for debridement and eschar excision of the ear and the neck, and I will wait for 24 hours, either whether there is any progression in the muscle which is exposed. If it gets devitalized, and then I will take the debridement.
Next team, I told you how you will manage the patient come to you after 2 hours of injury. Next team.
Ma'am,
Team 6.
Team
3. Team 3.
We'll remove the eschar and we'll cover it with moist dressing, and then we'll
because electrical burns is known to be a progressive in nature. We cannot give a
next team.
After initial resuscitation, ma'am, we'll proceed with the debridement. In the first sitting, we'll do a dressing and then have a next look after 48 hours in case of further devitalization or further debridement that is required.
All finished?
Yes, madam.
Name, ma'am.
Team 5, ma'am.
Team 5.
Team 5. Yes, still.
Ma'am, after initial resuscitation, ma'am, we'll go for an ECG, ma'am, to rule out any cardiac arrhythmias if present.
I'm saying how you will manage wound. Just give me an answer. Don't go here and there.
Ma'am, we'll wash the
If it
wound
is all
thoroughly.
right, then only I'm saying how you will manage this. I mean, how that is ruled out. How you will manage this wound.
Ma'am, we'll in the initial period, ma'am, we'll take the patient, we'll give a thorough wash with normal saline, ma'am. And for the ear, ma'am, we'll have to give an hydrogel dressing and then cover it, ma'am. And for the neck, ma'am, we have to give an occlusive dressing to prevent moisture loss and to prevent blowout. And ma'am, we'll have to take the patient for an early debridement, ma'am. We'll have to plan for an early debridement, ma'am. And we'll have to keep on assessing the patient every 24 hours to see for progression of the necrosis and take for further debridements if needed.
Early debridement.
Also, ma'am, we'll have to give him contour
What do you
dressing for
mean
the
by
remaining
early
part of the year.
debridement? Just be specific. What early debridement?
Tangential excision.
When limit, I'm saying what early, how much time? What is
Ma'am,
early?
ma'am, within 48 to 72 hours, ma'am, and now the recent guidelines is within 24 hours if possible, ma'am.
Anybody is remaining? No. All finished? All finished?
Yes, ma'am. Yes, ma'am.
Okay, it's
Ma'am,
a
also
high.
We have started with
Yes,
team D.
finished. Everything is finished. Just it's a high voltage electrical burn, and you have to initially be conservative. You have to dress with whatever hydrogel antiseptic dressings, and you cannot go for a tangential excision in the case of neck. You are not aware, how much deep. Can you see once this discharge comes out, all the muscles are exposed, and inner is also not aware. How can you do a it's not a radical, everything will slough off. You have to be very conservative. After it's a subacute debridement is required, not in the acute state. And that also too, only the necrosed tissue, if there is any viable or a doubtful viable tissue is there, you have to leave it. Then you have to do the serial conservative debridement. And after investigation, so that you are aware, how much deep we are with the vital structure, then only you will do the excision, final excision, and the cover. How can you do a tangential excision with such a, high voltage neck area? It's not a limb. Okay, it's not a scalp or somewhere else. It's a neck. Can you see after 2-3 dressings? Just see the scenario of his neck wound. Everything is sloughing out. Okay. Now, direct question is for unit for
team 1.
Team 1, ma'am.
Yeah.
So
Can you just tell me what is the?
You are not giving any mark to anyone.
No. 1 or 2 marks for
you can give
team.
Durga. There is a loose tissue. They can do the debridement. We cannot allow that infection also.
I have given. Just madam, let me tell you one thing. I repeat the question again. Just after 2 hours of injury, in between also I repeat the question. I'm not saying of this patient. I told.
But one team, no, madam. No. One team told the initial dressing and go for the debridement later on.
Not they said in the acute condition they were okay with the dressing, but they said we'll do the early debridement. It's not early, early debridement and cover. That is not done in these cases.
No, not early. Immediate cover, but
yeah. But I asked,
debridement.
I asked what early. She said 24 to 48 hours or something like this. Is not 48, so I cannot give the cover to these patients.
Direct question to team 1, madam.
Team 1.
2 marks is for team 6 because first answer was correct. This type of burn was correct. True electric arc and flame. So 2 marks for them.
Now team 1 questions, ma'am. 2 questions.
Yeah, team 1 direct question. What important investigation before doing any surgical intervention?
Team 1.
We would like to get a complete hemogram of the patient.
I'm saying what?
One.
What is the important? I'm not saying what is the one investigation which is required. The rest are okay. You will do all the, which is the one of the most important investigation which you will require.
Specifically for electrical burns, one important investigation is urine for myoglobin, and another would be ECG.
Next team.
Ma'am, before going to any wound management, I would like to go for color Doppler or to look for the vascular status of the neck.
I'm saying which one investigation, that is okay. Which one which is important, without that you cannot do. There are so many Dopplers.
CT of the
next.
Team 3.
Next team.
ECG.
Next team.
Team 4. If you don't know, next team 5.
Next.
Team 5.
Creatine phosphokinase and CKMB.
CPK.
Next team.
Team 6.
A real function test.
Huh?
Real function test.
All finished?
Yes, ma'am.
Most important before going for the surgical intervention is MRI with angio. Because with MRI, we have to see the soft tissue status, like these muscle, how deep they are, edematous, burned, necrosed, so that you have idea that you are just this millimeter, just superficial to these vessels. Okay, and the second is very important is the assessment of these vessels, whether they are thrombosed, internal jugular vein, carotid vessels, and then about the brachial plexus also. So this is the MRI. CT with CT only able to assess the soft tissue. If there is any this vertebral or a bony involvement, then with angio you can. Otherwise, you have to add one more MRI with angio after doing the CT. Okay.
Okay, ma'am. Ma'am, one more question to team 1, ma'am.
One more question. Okay. Just a minute. Yeah. Like if there is a nerve damage, then what is the mechanism of nerve damage in cases of electric burn? Can you tell me the 3 mechanisms?
Electric burn, the nerves have least resistance for the current flow, so therefore they are damaged the most.
It's not clear what you are saying.
Mechanism, ma'am is asking.
How the nerve damaged? 3. Just tell me the 3 mechanism. How there is a damage to the nerve?
So there is, ma'am, there is change in the membrane potential of the nerve because of the electric burn. Because of which.
Yeah, what are you saying?
Ma'am, there is a change in the resting membrane potential of the nerve, because of which nerves are unable to conduct the stimulus.
How I'm saying how. That's why I'm saying how. I mean, what is the mechanism?
Pathology.
How is the mechanism? How it causes conduction जो भी करता है block. Next team.
Ma'am, it is electroporation through the nerves and also ischemic.
What is this? What is this?
Also. Sorry, ma'am.
What is electroporation?
It is conduction of the electron, the charged electrons passage through the vessels, nerves and vessels.
It's not. But electroporation is correct, but you are not aware what. Next.
Team 3.
Next mechanism.
There is ischemia to the nerves, and there is also direct damage of the nerves.
Voice is not clear. Just what?
There may be direct damage to the nerves also, and there is ischemic necrosis of the nerves.
Third one.
Ischemic necrosis of the nerves now. The vasonervosum will be affected.
Okay. This is correct. One more partial.
One mark.
One mark to team 2.
We can give 1 mark.
Next, direct questions to team 2, ma'am. 2 direct questions. This will be the last questions.
Yeah. Okay, how you will manage this patient, after surgical debridement? What cover you will give? Why you will give that cover?
For the neck wound, after the serial debridement, I will.
After, your wound is ready, you have done the debridement. Now just tell me what cover you will give and why you will.
Ma'am, I would like to go for a flap cover. And my first choice would be
because of the vital structures.
If the vas.
That is okay. You are giving
What
flap
is the
cover.
flap?
Just let me what flap and why you are giving this flap.
So we can deltopectoral flap, then cervical.
I'm not saying the list of the flaps. You just tell me what you will do here. I'm asking first option only. Then I
would like to go for deltopectoral flap, right-sided deltopectoral flap for neck defect.
But after you will dissect, maybe some cavity or something will be there. So you will 1 stage or 2 stage? I mean, how you will give?
If after debridement there will be a defect, then we'll give a
Muscle flap cover can be given for the cavity.
Musculocutaneous
It's not, speak one by one. It's not clear. What are you saying?
Pectoralis major myocutaneous flap cover, ma'am. If
It will reach here. It will reach here. Just tell me. I'm saying, will it reach to this extent?
Trapezius muscle flap cover can also be.
Yeah, I'm saying of your second option only. Yes or no?
Yes, ma'am. Can reach.
Yes, ma'am.
How, so two stage you will divide and then, or how
We
you
have
will
to divide the origin also and the insertion based
Then
on.
you take this flap from, how you will reach there, pec major? You will divide in the second stage. What you will do?
Yes, ma'am. We will divide in the second stage.
No, partial answer is correct. But how? Why you are, going above the skin? You can tunnel the skin and you reach there, right?
Tunneling under, we can go for.
Okay. And reconstruct. First is 1 marks. Second is how you will manage this ear. After, debridement of this partial ear, necrosed ear, how you will manage the ear?
Ma'am, we'll debride this thing and we'll look for the cartilage, viability of the cartilage.
Only upper half, upper 1/3 is there. Everything is gone.
Even cartilage is gone.
Yeah, everything, full thickness.
We'll go for, we can use the posterior mastoid fascia cover for the upper cartilage which is left and skin grafting.
No, I mean, how to reconstruct?
We can take the mastoid fascia, and post-auricular mastoid fascia for the reconstruction.
And for the cartilage?
For cartilage, we can harvest from the costochondral rib, ma'am. For rib cartilage graft, we can use.
Where you will seeing a mastoid fascia? It's not clear. Next team.
You can reconstruct the
because there is a more than 50% loss of the ear, then we'll plan for a staged reconstruction with costochondral graft, ma'am. Because the post-auricular skin looks unaffected.
So we can
go for a totally.
I think once you will go with the debridement, then I don't think there will be, you will able to have a sufficient amount of the skin. Next team.
Team 4.
We can harvest rib cartilage and temporoparietal fascia flap. After carving the rib cartilage out for the lower 2/3 of the framework, we can harvest a temporoparietal fascia flap and then graft the skin. A skin graft on it.
like a Nagata technique.
2 stage, 1 stage.
2 stage, ma'am. Nagata technique 2 stage.
इसमें 2 stage?
We can do it in 1 stage, ma'am. We can give us cartilage in a strut for the cephaloconchal angle.
Yeah, this is a better option. You can give 1 marks to them.
Yeah. Now the all questions over for all teams. The other seniors are judges, one question to each team.
Sorry to interrupt, ma'am.
Angeline, ma'am.
Yes, madam. Sir, tell me what.
You'd like to ask one question to each team, ma'am?
No, I think, madam, we have 3 more spotters to go.
3 more spotters. Time
is
then
up.
uniformly, if you want to give some summary.
Yeah, I'll just summarize this thing.
Okay.
It's a high voltage electrical burn involving only this portion has been given. We should actually find out whether there is any other area that is affected, especially if this is an entry wound. We should actually look for the exit, whether there is any other exit wound that is there. That is another important point that has not been discussed. So that has to be thought of. And reconstruction wise, the planning and reconstruction has been extensively dealt. I feel PMMC will reach this area.
Yeah, definitely. But they should be confident in saying yes, they say then they are hesitant,
That is the only thing. They should be confident. And all the flaps from the posterior aspect, the trapezius things can be easily planned off. And madam has extensively dealt with it. I think we'll go to the next spotter, madam. Thank you.
Thank you, madam.
Okay, ma'am. Thank you.
fourth spotter. That.
I would like to request the team 4 to introduce themselves, and I request Shailesh sir to be the primary panelist for this.
Yeah.
Quarter.
Good evening, all the teams. My one request is that we should not put the camera off. So all the teams should have the camera on all the time, because I am observing that some teams are putting the camera off in between. It's not correct in the team spirit that the camera should not be put off so that we can see you all the time. These are going to be the quick spotters. They are not going to be lengthy discussions. So I have created 12 spotters, 2 spotters each for each team. And it is going to be a quick answer, and you will have to pass it on if you don't know the answer, because it's not going to be a lengthy discussion. It's like a more like an objective test. So shall we start with team 4?
Yes, sir.
Okay. So this is a banana leaf dressing. Who invented this banana leaf dressing?
Not sure, sir.
Don't know.
Next
Team 5.
Pass to team 5.
Team 5.
Team 6.
Team 6.
Gail.
What?
Gail. Parry. Ambrose Parry.
Next.
Team 1.
Team 1. Team 2.
Team 2.
Dr. Vijay Chonget.
Can I modify the question saying that who has popularized this dressing in India?
Dr.
Sir,
Matangi.
1 minute.
Team 3.
We modified the question, so team 4 has to answer
Yes,
first.
again a chance.
Team
Who has
Dr. Matangi
popularized this?
Sir,
Team
Dr.
4.
Matangi
Matangi
Ramakrishnan.
Ramakrishnan from Tamil Nadu.
Sir, I told it first.
No.
Next. Team 5. Team
It
6.
is not correct.
Sir, Dr. Vartak.
Team
Dr.
1.
Vartak,
Team
sir.
1.
Team 6 is over. Team 6 is over. Go one by one. Team 6. Otherwise, say pass. Say pass otherwise.
Pass. You can give an
Team 1.
hint.
Yes.
No, sir. No hints.
No hint, no
No
hint.
hints now.
So team 1. Pass.
Team 2. Team 3.
Sir,
Now you give the hint. Now you give the hint.
Excuse me, ma'am.
Dr. Keshwan.
Team 3 actually wants to answer, sir. Team 3.
Yes.
Sir,
Team
is it
3?
Professor Mohan?
Not.
So all the answers are wrong. This
So,
is
you
popularized
give
by Dr. Madhuri Gore in Science
Yeah.
Hospital, and she published a paper in 2003 where she beautifully showed the use of banana leaf dressing, and she has popularized this technique, and it has been still used for a long time. At the time there was a skin bank in Science Hospital. So this answer is popularized by Dr. Madhuri Gore, madam. She has a paper in Burns Journal in 2003. So team 4, question 2, are you ready?
We are not.
Yes. So this is a synthetic dermal substitute called Novosorb BTM. What is the long form of BTM?
As a biodegradable temporizing matrix.
Correct.
Okay.
So
2
2
marks.
marks to team 4.
Next team
We
5
go to
questions.
the team 5 now. First question. Which fish skin is commonly used to treat these burns?
Team 5.
Name
Team
the
5.
fish.
Salmon skin.
Next.
Team
Team
6.
6.
Team 6.
You're not audible.
Team 1.
Pass.
Either say answer or pass.
Pass.
Team 1.
Team 2.
Tilapia skin.
Yes.
Tilapia skin. Fish skin.
Who is
Team 2.
answering this?
Team 2.
Tilapia fish?
Correct.
Team 2.
That's a correct answer. Team 2. Team 2 gets 1 mark, right?
Yeah.
Yes. Next.
Team 5
Next
direct
question. Team
question.
5.
Team 5 direct question.
Identify these gentlemen. They are the inventors of Integra.
Pass.
Team 6.
Pass.
Team
1.
7.
Bird. First gentleman is Bird.
Yes.
Team 1.
First gentleman is Bird. Oh.
Team 2.
Team 2.
John Berg, sir.
John Burke, and one more inventor is
Team
starting with
3.
First one is Burke and second one is Yanas.
Yes, that's the correct answer.
Team 3 1.
So they have invented
Team
Integra. Yes, team 3, right? Team 3.
Yes.
Team 3 got the answer. So these are the pioneers of Integra, and they formed it in 1981, and they published their first paper in 1981 in Annals of Surgery, and they are known as inventors of dermal substitute. So we go to the team 6 now. Question 1. The development of BTM was done in which hospital? Team 6. Pass.
Pass.
Team 1.
Pass.
Pass.
Team
Team
2.
Srina's Hospital.
Srina's Hospital in Australia.
Which?
Srina's Hospital in Australia.
Next.
Team 3. Team 3. Team
Team 4.
Sir, Adelaide.
Adelaide Center, sir. Royal Adelaide.
Royal Adelaide Hospital.
No, you can't answer in jointly. You have to answer one by one. So who answered this now?
Team 3.
Team 4.
Team 4.
Team 4.
Team 4 is the correct answer. It's a Royal Adelaide Hospital in Australia, and that's a correct answer. And this was Professor Greenwood who has developed this, and this happened after Bali bombing, when there are more than 200 extreme casualties which were there in Australia, which were flown back from Bali to Australia, and they tried to use Integra in all these cases, and they all got infected because they had reached late. And then they decided to develop this synthetic substitute, and this is why this was developed in Adelaide Hospital, because they found a need to develop a synthetic substitute which can fight infection. So we go to question 6, team 6. Next question. In addition to bovine collagen in metriderm, what it is made up of? What is the other part?
In addition to the question, the complete question.
In addition to bovine collagen, metriderm is made up of what? Pass.
Bovine collagen, hydrocolloids, sir.
No. Team
1. Team 1.
Elastin. It is collagen. Elastin. Collagen elastin template.
Team 2.
Elastin from bovine ligamentum mucosa, sir.
I want a complete answer.
Elastin polymers
It's not a complete answer. I want to know the complete answer.
Elastin.
Fibrosylate.
Bovine ligamentum mucosa, so we take the elastin and the bovine collagen.
Can you repeat? Can you repeat the answer? You are giving the right answer. The guy is giving the right answer. I don't know his name. What it is? You have to completely spell it out.
Fibrosylate
is hydrosilate, but I give this to you. So elastin hydrosilate is the chemical. So 1 bonus mark to team 2. We move to
Team 1.
Now. Who has invented this dressing? Or who has popularized this dressing? Team 1.
Ambroise Pare.
Next team. Team 2.
Dr. Professor Keswani, sir.
Yes, it's a correct answer. Professor Keswani started using this potato peel, where he used to have the boiled potato. They used to harvest from Tata Memorial Hospital. They used to take it and use it on the bandages, and they used to regularly put it on the dressings. And he has published a very beautiful paper in 1991, where he has used this very, very successfully. So we go to team 1, question 2. So this is a nose of BTM being applied for the foot contracture reconstruction. And now this is being, the top layer is being removed. What is this called? There is a particular term for this. Team 1.
Silicon sheet removal.
Silicon sheet removal.
Team 2.
Sir, silicon peel.
Team 3.
Delamination, sir.
Yes,
Correct.
that's the correct answer. And it is not silicon. In BTM, it's called polyurethane. So it's a polyurethane membrane, and it is called delamination. It's a correct answer.
Team 2, question 1, sir.
Team 2, question 1. What is the dermal degeneration matrix made up of?
Sir, Integra is the superficial layer is made by silicon, and inner layer is made by bovine collagen, chondroitin sulfate from the shark, and fibroblast.
Correct. Bovine collagen and chondroitin 6-sulfate is the answer.
2 marks.
We go to
Two.
question 2, team 2. Who invented these instruments?
Sir,
Humpy, sir.
First
Humpy
image is
rectangular
Yes.
frame, this thing.
Yes, correct. And it's very beautiful that Humby was not a doctor, for your information. Humby was a dresser, and he was working at Great Ormond Street Hospital under a plastic and general surgeon. And around the World War II, he developed all these equipment. So first on the left hand side is a rectangular frame so that we can flatten the surface. And right hand side is the handle where he has provided this special rod so that he can control the depth or the caliber of the graft. We go to team 3.
Yes.
Question 1. What is this layer called? This is nose of BTM, synthetic dermal substitute.
There's a polyurethane foam, on top of it are silicone layers.
What is the name of the layer which is marked in blue, which is the topmost layer?
Silicone layers.
Next team 4.
It is also a polyurethane outer layer only, sir.
But it's not biodegradable.
Team 5.
So it's sealing membrane.
Yes, that's the answer. Sealing membrane is the answer. That's the correct answer. You get bonus point.
1 mark. Team 5.
Yes.
Next
Team
question.
question 2.
Last question.
What surgical procedure has been done in this case?
Debridement and Integra application, sir.
Next team 4.
Collagen, wet collagen.
Wait. Team 3.
Sir, it is cleaning, hydrotherapy and wet collagen applications.
Yes, that's the correct answer. It's a wet collagen application which has been done. I give it to you because you answered in time. So I think team 3 should get the 2 points for the second question. It's a collagen application done for the facial burns. I think with this we finish. I think, have you finished?
Yes, sir. Yes, sir.
Yes,
Thank you.
sir.
Now we will move to the spot
I
of
think
ma'am.
we have finished.
Judge, anything want to, Dr. Sanjeev Uppal, sir? Would you like to ask anything?
No, just wanted to ask about the when and what are the indications for these dermal substitutes in general. So, can you list 3 indications for the team question, team 1 or 2?
It starts with 4, sir.
Start with team 4. Team 4, this question for
Team
you.
4.
1, 2, 3 indications for dermal substitutes application.
So one can be lack of substantial donor areas. So lack of donor area and any
lack of donor
like joints.
Not donor area.
Sir, graft STSD donor area. If bilateral thighs are involved and more body surface area is involved, then to provide cover we can use dermal substitute. Second indication will be for areas where we have joint, like the wrist, the elbows, the knees, the popliteal fossas. There we can use a dermal substitute before placing a graft.
And in case any vital structures like tendons are like over the dorsum of the foot or over the dorsum of the hands are visible, then a PTM or a dermal substitute can be utilized.
I think we can ask the next team for more different answer.
So could you please repeat the question, sir? The question is not very clear, sir. Could you please repeat the question?
Question is, when do you plan to apply dermal substitutes? Indications in your view. 1, 2, 3.
Indications for use of dermal substitutes.
Sir, we will
patient
use
might
dermal
ask for some,
We'll use dermal substitutes, sir, in areas where we need a good skin pliability and we want the good layer of dermal.
A scaffold to place a split thickness skin graft on, sir, and areas where we need a scaffold to place the STSG on, sir. So we will be using dermal substitutes in such places, sir.
So that we get a good dermal layers.
Okay, I think we can
And
give
sir, maybe
one more to
exposed
this team.
Team 6.
Deep dermal burns and deep second degree and third degree burns are the ideal cases. Along with the others, what they are told, additional point is that deep dermal and the third degree burns.
I think Dr. Ranale will be, since he's using a lot
So
of
basically,
these
dermal
products.
substitutes we use. I think now it's the question is closed. I think, and we're not going to give marks, right? We are just going to discuss it.
So,
So the dermal substitutes are
Sai, would you
basically
like to
used.
give any mark to any team?
Dr.
You
Sanjay.
asked the three indications.
The second team which we pass question to gets the 1 mark. You pass to the
1 mark to team 4.
Yes.
1 mark, sir.
Team 5.
Sir, you have to ask total 6 questions, sir. Because you have started with
nowadays
otherwise it is unequal.
unequal. Otherwise, you have to close.
Team 5.
As okay, so we should stop and we should further.
So then we will not give marks for this.
Then we will not give marks to this question.
Okay, sir. Okay.
So this question is cancelled.
Okay. Now moving to spotter 5, sir.
Can I make one, give them one information?
Yes, sir. Yes,
sir.
Dr. Keswani's full name is Dr. M.H. Keswani. And his son is also a well-known plastic surgeon, especially in the field of burns, settling the burn skin banks, Dr. Sunil Keswani. And there was a time when Dr. Keswani was trying to popularize this potato peel. He used to send by post to all the departments of the country a square-shaped potato peel piece, which was sterilized and sent to us, and it was to be re-sterilized. So we have all used it when he used to send it by post. This is for your information.
Thank you, sir.
That was the enthusiasm.
Thank you, sir.
We have been fortunate enough to use it in Wadia Children's Hospital regularly for a long time.
Team 5.
Now we move to spotter 5, ma'am.
Yeah.
I would like to request Arun Bhatnagar, sir, to please be the panelist. And team 5, please introduce yourself to the panelist and start. We'll start.
Yes.
Good evening, sir. I'm Dr. Megha, sir, from Southeastern Railway Central Hospital, Kolkata, sir. I'm a second-year resident.
I'm Dr. Utsav Shah from Southeastern Railway, and second-year resident.
Was from Kolkata.
Yes, sir.
Okay. So you see this spotter. What is your complete diagnosis for these patients? You see carefully the wounds and give me the diagnosis.
Sir,
Correct and complete diagnosis.
There is a third degree burns over the left hand, dorsum of the hand, and the distal forearm, along with a few areas of second degree deep burns. And on the right hand, there is a second degree superficial burns over the dorsum and the dorsum of the index finger.
Okay, correct.
2 marks.
Yes. And second question is, what are the 2 expected complications if such burns are left untreated in left hand?
In the left hand, if we leave this hand untreated and we don't give proper splintage, then the claw hand deformity can occur here. And other contractures like botonier deformities can also occur.
And the wrist joint, because it is at the level of the joint.
Wrist joint flexion contracture can also occur.
I think it's not completely answer, so
we'll
pass.
Team 6.
Team 6.
There can be a first web space contracture also with yes, and then
see, I want to know only 2 important complications. Burn is not extending into the finger. It's not deep in the finger, just a hint.
The web space contractor, first web space contractor is the one, sir, along with the flexion contraction of the wrist.
No, pass.
The extension contractor.
Team 1.
Dorsal contracture of the left hand, and another one is claw hand deformity. And burns in the direction.
Partly answered. I think, ma'am, we can give 1 mark to them.
Team 5 gets 1 mark, and team
Yes.
1 gets 1 mark.
Team 1 gets 1 mark.
Okay, ma'am.
Yes.
Next, moving to team 6, direct questions, ma'am. 2 questions.
Team 6 direct question is, what should be the position of hand when keeping this hand in dressings?
That's the intrinsic plus position where the wrist is extended at 35 degrees, 35 to 40 degrees, and flexion metacarpophalangeal joint flexion of up to 70 degrees, and interphalangeal joint in extension.
Are they in complete extension? All the IP joints?
Distal interphalangeal joints in extensions.
Okay, the second part is, what is the difference between functional position of the hand and position of rest? Did you get the question? What is the
Yes, sir.
functional position of the hand and what is the position of rest when hand sustains the injury?
So when the hand sustains the injury, the position of comfort will be it will be in the position of comfort, sir, where the metacarpophalangeal there will be various degrees of flexion at the IP joints, and thumb will be adducted, and wrist in flexion, sir.
What about IP joints? Didn't mention?
IP joint in flexion, sir. IP joint in flexion, sir.
Pass. They answered 1 question correctly, so 2 marks to them. Second question is passed.
Team 1.
The functional position is the position of in which we fix the hand and arthrodesis.
So the wrist will be in slight extension, 10 to 20 degrees, and MCP joint in flexion, and IP joint in 5 degree flexion. MCP joint in 90 degree flexion, and thumb will be abducted and pronated. And the position of rest, the wrist is in slight extension, 10 to 20 degree with slight ulnar deviation. And the MCP and IP joints are in flexion with progressively increasing order. The MCP joint is in MCP joint of index finger is 20 degree flexion, followed by middle finger 25 degree, ring finger 30 degree, and little finger little finger 40 degree, and PIP 40 degree flexion in index finger, 45 degree in middle finger, 50 degree in ring finger, and 55 degree in little finger, and DIP in 0 to 5 degree flexion.
You have put in a lot of mathematics. No, it's not the very correct answer.
Team 2.
Pass to team 2.
Pass.
Sir, functional position would be the wrist in 20 to 30 degree of extension, and MCP joint in 70 to 90 degree of flexion, and complete extension of IP joints of the fingers. And for thumb, it is 40 to 50 degree of pronation, and pronation and palmar abduction with the extension of IP joints. This is
most of you people are right in describing the functional position. I'm asking about the position of rest.
Position of rest is wrist is in flexion, 10 to 20 degree of flexion of the wrist joint, and 50 to 70 degree of MCP flexion, and IP joints also in flexion. And thumb,
What about MP joint?
50 to 70 degree of flexion, sir. Flexion and extension of MCP joint, sir.
No.
I think pass. We can pass.
Sir, in the resting
Team
position, the hand will be in cascade position.
The
It will
relaxed
be-
position of cascade, sir, when we rest the hand on the table.
So
Say it again. Say it again.
The resting position is the position when the hand is kept neutrally in a relaxed position with the cascade maintained.
The basic problem is this: you are trying to keep the hand. Hand itself goes in the position of
Yes,
rest.
sir.
You
Cascade.
know,
Form of a
functional position
cascade
you
will
have
go.
to keep. So,
Yes.
Yes, sir. Yes.
so what do you say?
Sir, MCPs will be in 45 degrees flexion and PIP will be in around 30 degrees flexion.
Anyway,
DIP.
chalo, I think, ma'am, we pass on to the next team.
Team 4.
Team 4.
So
Direct question.
Team 4.
functional position of hand would be
Not
rest at
functional position.
No.
Rest.
Rest.
You can just show my.
This will be a rest position, sir.
Rest is this.
Hmm.
Intrinsic
See,
left hand is
chalo,
rest.
next.
So this is the rest position, sir.
Team 5.
And the hand
Sir,
will be in
the wrist will be in 20 degrees of flexion. There is the flexion as the MP joint,
man, sure,
along
sure.
with varying degrees of
Oh.
flexion at the PIP and DIP joint.
Sir, I think all teams are over now.
All are over,
Team
sir.
5,
You
sir.
have to
Team
tell
5.
the answer.
Just I think judges will give you the correct answer. I just give you a hint. See, when you see any hand which develops the contractures, see, because it goes in the position of hand, that's why it develops the contractures. And you look, most of the contractures are not right? They are the hand. Dorsum hand pe burn hai. They are going into extension contracture. That's why hand is going into. Anyway, chalo, pass on. I think we can go to direct question. Next team.
Team 1, sir.
This is third team, hai na?
Yes.
So it is. What should be the ideal management approach for left hand? What should be the ideal management approach for the left hand? You are talking today.
For this hand, it is the second degree lead to third degree that we can appreciate. Ideal would be to first put the patient on dressing. On the third to fifth postburn day, we'd like to go for tangential excision and skin graft resurfacing if along with sir, at our institute we would go for tangential excision along with BTM or any dermal matrix replacement in the first stage, and at a later stage we would like to graft since it is the dorsum of the hand, and we would like a supple skin over there.
Second part is correct, but first part is not correct. So I give you 1 mark because you are going to still wait for another few more days. Right? Next, pass. 1 mark, Madam Inko.
Yes, sir.
And first half of question is passed.
Sir, can you repeat the question, please, for the first half?
What is the my question was, what should be the ideal management approach of this patient when you are seeing him today?
Sir, we'll do the serial debridement of the left hand, which is sloughed up, and along with that, daily dressing and keep a wave spacer between the fingers and put a hand in a functional position to reduce the edema and maintain the position. Then after slough gets debrided, we will do debridement and grafting of the patient.
We are mixing two answers. First part was only not correct. That I think you had said correctly. You are taking patient directly to the surgery. You are not waiting for another 2 to 3 days with dressing, all those things. Right, ma'am, we can give 1 mark to them because second part they are not answering correctly. Okay. So second question for team.
Team 6.
Yes. Team 6. What is the tangential excision in burns and how it differs from the serial excision?
Team 6, we had 2 questions.
Yeah.
Team 1, sir. Team 1, sir. Team 1.
Team 1.
Team 1. Team 1.
So can you please repeat the question?
What is the tangential excision in burns and how it differs from the serial excision?
See, so tangential excision is excision down to the level of the dermis, viable dermis, obviously be able to appreciate his pinpoint bleeding. In serial excision, we like to go for focused debridement of the necrotic areas, and it could be down to the level of dermis, subcutaneous tissue, or the fascia, wherever we find the viable bed.
I think correct. I think they are correct.
2
So,
marks, sir.
yes, 2 marks.
Now questions, 2 questions to team 2, sir. Team 2.
Team 2.
Next 2. So, name the splints used in the physiotherapy while healing of these hand burns.
Sir,
Name the splints used in physiotherapy of healing of these hand burns.
sir, we can give a thermoplastic splint, thermoplastic functional splint. Then we can also give a plaster of Paris functional position splint.
So we can,
While-
not in this case, we can use pop-up splints also, functional thermoplastic pop-up and
the dynamic thermoplastic and static thermoplastic.
Yes, that's why I wanted to listen. You
Static.
have to use combination of static and
Static and
dynamic sprint. Early in stage, you will use the static sprint, and then you can go shift on to dynamic sprint. Right. So 2 marks to them.
Second question, sir.
Second question. What are the common deformities of the digits in the deep hand burns?
Sir, commonly bottlenose deformity can occur, then swan neck deformity, and also mallet finger.
leading
Right.
to one neck deformity.
Okay. I think both are correct.
Now questions to
Last one,
team 2.
Team 3.
Team 2.
Team 3, 2 questions.
What are the indications for pressure garments in the hand burns? What are the indications for the pressure garments in hand burns?
Hypertrophy. So to prevent hypertrophy of scars when the scar is in the healing stage and there is no raw area, we'll go for pressure garment application.
Immature scars, hypertrophy.
Post
SSD also.
Irrespective of burns, whether they are on palmar surface or dorsal surface.
Usually, sir, we go for the dorsal surface because the skin is thin over there and no remodeling will be there over the dorsal skin.
Okay, it was a leading to answer you. Anyway, it's fine. Any other indication?
Post SSG. Post SSG, sir, to prevent the remodeling and loss of graft. Okay.
No.
To reduce edema also, sir.
Yes, correct.
2 marks, sir.
2 marks, yes.
Second question.
2 questions.
What are the skin substitutes used in the serial excision burns? I'm not talking of tangential excision. What are the skin substitutes used in the serial excision burns of the hand? The patient is in front of you.
Post serial excision, sir, there will be dermal and epidermal loss, and mostly vital structures might be exposed. So we can go for either integra placement and then second stage reconstruction, or BTM placement, or we can go for martyrdom placement, which is only a dermal substitute, and over that we can put SSG at the same time.
Oh, you say if it's a deep derma burn, you don't need to put any dermal substitutes, You can use them only when dermis is
Vital
missing.
structures are exposed.
What are those vital structures?
Tendons to promote the tendon gliding and all, we need to give a supple skin.
So it has to be a deep burn,
Yes.
And then what will you use it? What are the substitute you will like to use in this case?
Sir, we can go for integra or BTM placement, sir. And second stage, we can go for SSG over them after peeling the.
It's fine. I think, ma'am, we can give 2 marks then.
Okay, sir.
Team 4, 2 questions, sir. Last.
Team 4, sir.
Team 4.
Achha, team 4, 2 questions, na?
Last 2 questions.
Yes. So, role of early excision in burns.
In early excision, sir, the advantage is that
Yes.
There is less, the graft take is better, duration of stay in the hospital reduces, the rate of infection also comes down, depending on when we have done the early excision.
One more important.
Rate of the blood loss also is less. If it is doing, we are doing it in the early
Yes, then all
24 hours,
cause, yes.
then the blood loss is also less. And
see, there are three important things. Two you told, one is left.
so blood loss, better graft take, lesser hospital stay.
Faster rehabilitation.
Pass.
Sir, it reduces the cytokine storm
Oh, no.
to set in.
Yes.
And less amount
Occurs
of
in more
necrosis.
extensive, must know. Third important point why you would like to do early excision in hand burns as compared to rest of the areas.
To
Rest of the area you may allow to heal.
To preserve the hand function, sir.
And
Yes.
contracture at a
Yes,
later
that's
date.
the answer I
Prevent
want.
contracture.
Yes, sir. For early functional recovery, you want to go. Rest of the area you can allow to heal with secondary intention or dressings or whatever it is. Right? So
One mark.
1 marks to them and 1 mark to
For
them.
4, 1 for 5.
Yes.
Okay.
Next, second question, sir. Last question to team 4.
Last question is how can you prevent deformities in deep burns of the hand?
So first of all, we'll go for splintage in the functional position of the hand. Early excision.
You start from the when you have seen the patient and he's a deep burn. See, left hand is a deep burn. So
Yes.
how will you prevent the deformity in these patients, right from management to treatment?
We would, if in case of circumferential burns, we would first
Yes.
like to evaluate for a compartment syndrome if there's any compartment syndrome present.
True.
If not,
One.
If it is present, then we go for management of compartment syndrome with fasciotomies. After that, if there is no compartment syndrome present, we choose to splint the hand in the functional position and maintain splintage. We also go for early excision of the burnt area and grafting so that there is better rehabilitation, lesser hospital stay, and the function of the hand can be maintained.
Anything else?
And use of as soon as the graft take is done, then we'll proceed with the use of continuous compression garments, silicone gel sheet, scar massage,
Scar therapy.
and physiotherapy. Scar therapy.
2 points are still left. One in early management of the wound and another is in early management of the healed one. I think we should pass on.
So proper hand elevation, sir.
Yes, very important. See, in
sir,
all of the hand burns, proper hand elevation and movements is very important. You have to take down the edema before you do anything, right?
And sir, passive range of motion exercises for the fingers
and after healing phase.
After healing phase, we'll do passive as well as active range of motion physiotherapy.
Physiotherapy and splinting, right?
And splinting and
Yes.
massage.
Dynamic is splinting and physiotherapy. Even after you have done this early skin grafting, you need to mobilize the hand, right? So dynamic is splinting is very important.
Okay,
So
sir. One
I think
mark.
one marks, yes.
I think we are done with the questions. Ma'am, I think if you allow, can we move to the 6th portal?
Yes, sir.
I have kept my time.
Yes, madam. We'll have to.
Madam, if you want to give any gist of the spotter.
No, just as hand burns are very important, they should be managed properly in the early phase itself. Otherwise, they are likely to go for the sequelae in the later stage. So we have discussed all the immediate management, skin cover, splinting, and pressure garments. All that has to be kept in mind. That's the gist that I want to pass on. Thank you.
Thank you. Now, moving to last portal, I would like to request Uday Balakrishna Bhatt sir to be the panelist. And team 6, kindly introduce yourself.
Good evening, sir. I am Dr. Venugopal, second year postgraduate from Bangalore Medical College.
Dr. Nadashri Iyer, second year postgraduate from Bangalore Medical.
Yeah. This patient has sustained burns injury 3 years ago. She was admitted elsewhere, she was treated elsewhere, and a couple of operations have been done elsewhere. And this is how she has In this stage, she has been referred to a tertiary referral center approximately 3 years after the injury, after the initial injury. Now tell us what would be the etiology of this injury, this burns injury.
So, since it's a female and more over the face, it can be a vitriol arch. That can be a possibility, sir. And
No,
it
just
can be
because she is a female, you feel it is acid injury, or there is some other logical ways of doing it?
On the face, is mainly on the exposed area of the body, and face and neck on one side, indirectly it may
Correct.
give a hint to is vitriol arch.
Yeah. Anything else that would lead to the diagnosis of acid injury, acid burns? Any
And
other finding?
yes, and like here we can make out like more damage is in the upper part of the body, and there's a in the
Yes.
vitriol arch we
Other
can see
than
that
that, any specific finding that will lead to your diagnosis?
Yes, sir, the involvement of cartilage, eye, the ear and eye.
Involvement of the eye, correct? Involvement of the sclera.
Yes.
Okay, assuming this is
2 marks
acid
for the
injury.
first question.
Yes, yes, madam.
Yes. Second question to team 6.
Second question, all right. What do you think should be the sequence of treatment in this patient? How many operations will she require?
First thing is for the initial resuscitation, one thing, and like first, my first and foremost will be to prevent the involvement of the further involvement of the vital structures like eye, and like for that need the first initial debridement, and then after that can be.
No, where is the debridement? Everything is healed now. She
Okay,
has
for
come
this
to us
right now
now.
for this patient, yes, sir. Like first thing
How
is
many operations will she require now on?
sir, one she required for ectropion correction, sir, and one for
Okay.
the contracture of the neck, and one for the ear reconstructions. And nose reconstruction, even nose actually the just a functional reconstruction is required for the nose, because the aesthetic reconstruction is required. Functional is not involved, and the angle of the mouth is also involved, and that also has to be involved.
Yes. So what should be the sequence of these operations?
First, I'll go with eye and then with the neck, sir. And after neck release, the mouth we can wait and like with the neck correction, whether the mouth opening will get corrected or not, we can see it. And if it's not get corrected, then we have to go for the mouth.
Yeah,
And
what about
last,
the neck?
Sir, the
Neck.
eye first, second is the neck, sir. Once the neck
Okay.
contracture release is done, then we look for whether sometimes the neck contracture release will automatically correct the ectropion of the lips. So if that is not there, then we have to go with the lip. This one, then I'll go with the ear and the nose, because these are both are aesthetically, not functionally more important.
All right. Thank
Because
you.
no, in this patient, nose
So
is
2
like
marks will be allotted to
Yeah.
6. Okay.
And
Team 1 now.
team 1.
2 questions to team 1.
This was team 1, madam. The
Team
present
six.
district. They answered both the questions.
Yes,
That
sir.
is
Team six,
over,
sir.
sir. Now next 2
Yeah.
questions will go to team 1.
Yeah. So can you project the next slide of this? There is a next slide.
Okay, sir.
Sir, those are post-op.
Yeah. But there is a question in that, madam. There is a question in
You
that.
want me to project those
Yeah.
things?
Project
Then
yes,
you
yes.
show in, we kept those things in post-op.
All right. Doesn't matter.
You want
So
me to show,
for the next,
we'll go there.
that is all right. Yeah, that is all right. For the next is saying what should be the plan for nasal reconstruction?
Yes, sir.
Team 1.
Team 1.
Where there is alar retraction over right side, I would like to correct it with in 3 layers using a cartilage graft and
mucosal lining.
skin and mucosal lining. The FTSG can be used for external, and internal can be done from raising the mucosal flap.
No. Pass it on to the next team.
We can pass it
Wrong
on.
answer.
Sir, we will do the tissue expansion for forehead flap cover for the mucosal lining, as well as the skin, as well as the dorsum of the nose defect reconstruction, sir.
So we'll
So
Complete your answer. Give me a complete answer.
So for nasal reconstruction, we will put a tissue expander and do the forehead flap cover for the mucosal lining as well as the skin lining, and
Framework from
and
the
framework costochondral
secondary procedure from the conchal cartilages.
Thank you. Yeah, correct answer. That is passed on question, correct? So they get 1 mark
yes,
for this.
1 mark.
So let us go back to the previous team.
Team 1.
Team 1.
Team 1 again. Now, can you comment on the right side of the cheek? What kind of scar is that? Right side of the cheek and upper lip.
It's a hypertrophic scarring, sir. Looks like a hypertrophic
The right
scarring.
side of the cheek, the malar region. Comment on the malar region. What kind of graft is that? There is a graft. You can see a graft, no? Okay, pass it on to the next.
Team 2.
Sir, it's a hypopigmented scarring over the cheek with
No, I'm telling you, it is a skin graft on the right on the cheek. So, what kind of graft is this? And what is your opinion about this?
It looks like a full thickness skin graft with edging of hypopigmentation over the cheek.
All right. Yeah. Thank you. Now they get 1 point, madam, for
Yes,
this.
sir.
Now,
Direct questions now to team 2.
Yeah.
Two direct questions.
So how many teams are over? 1 team is over, no? One
teams
or two?
are over.
2 teams
Two
over.
teams are over.
Okay. To the next team, can you tell us the aesthetic units of the face and their relevance here?
It is there are 12 aesthetic units of face.
9.
14. It is forehead, bilateral, supraorbital, and then infraorbital, temple, zygomatic, and we have the lip. In that also, each lip is divided into upper lip 3 subunits and lower lip 1 subunit, and then malar region, and then parotidomacetic area. And lower lip that. And
All right.
also we have the separate.
So 12 aesthetic units, correct?
Yes, ma'am. Yes, sir.
Yes. Now the second question, correct for you?
Yes, sir.
There is a direct question. Tell us the aesthetic subunits of the nose.
Sir, it is the dorsum and the lateral side wall, the tip and columella, alar subunits,
and triangle between the ala and lateral.
Supratip, tip complex, columella, and
Yeah. All right. How many total? Just give us how many unpaired and how many paired? How many unpaired and how many paired?
3 unpaired, the dorsum, tip, and the columellar, and the lateral side wall, alar subunits are paired, sir.
Oh, thank you. You get both right, both the questions right. Let us move on to the next team.
Team 3, sir.
Third, team 3.
Yeah. Now somebody told that she requires a forehead flap, correct? So tell me, what should be the dimensions of this forehead flap? How many subunits you are going to cover? And what should be, anyway, let us stop at that. How many subunits you need to cover? What is lost and what you want to reconstruct? How many subunits have been lost and how many you want to reconstruct?
So after scar excision, the subunits lost would be a part of lateral wall at the ala on the right side. And also columella partials.
Yes.
So we'll go for a forehead paramedian flap. We'll basically reconstruct the lateral parts of the lateral parts of the nose, including the ala, the lateral wall of the nose, and the.
If the left side is all right, left ala is all right, you feel?
Partially.
Or something needs to be done there as well.
There also it needs to be done, sir. But the alar wing is absent on the left side also, sir. Even that should be reconstructed.
Yeah.
The distal part of the flap should be designed in a way to cover all the tree.
Yes. And what should be the lining?
Mucosa lining, sir, we need, so we can use SSD also, sir, with the stenting.
We can use
Or
what?
we can fold the flap on it itself to create the lining.
Very good. And tell us the
And,
blood supply. This flap. What is the vascular basis?
So supratrochlear artery.
Supratrochlear?
Artery for paramedian flaps.
One or both?
Supratrochlear, supraorbital.
And cleans.
One.
Yeah.
Unilateral, sir. One side.
Yeah, it is only supratrochlear. That is
Supratrochlear,
right.
one
Right.
side.
Just tell us the
Unilateral.
plane of elevation. Is it the same all along or
No,
it changes?
no, sir, it will change. To include the artery, we have to go deeper when we come near the when we come down till the eyebrow, there we have to go underneath the frontalis muscles.
Yeah, all right. Thank you. You got both right. Okay. So next team.
Team 4, sir.
Team 4, sir.
How many teams are left, madam? Now 2, no?
2 are left.
2 left.
Yeah.
Who described it? Who described the static elements of the schools?
So for the next team, what do you think is wrong with the eyes and what should be done to the right eye?
There's a symblepharon on the right side, sir, with and it that needs to be released. And then after the release, the FTSG can be put on the defect. That is.
Yes. Anything else that is wrong?
Lateral canthoplasty might also be needed, sir.
Lateral or medial?
Medial.
Which canthoplasty?
Medial,
Lateral
sir.
or medial?
Medial, sir.
Medial. Who describe, second question for you is, who describe these units, aesthetic units of the face? Of the nose, sorry, aesthetic units of the nose. Can it be passed on?
Team 5.
Budget.
Team 6.
And
Sir,
Manic.
budget and Manic.
Okay. Manic and budget. All right. Thank you. So the next team gets 1 mark.
Yes,
And
sir.
the
Next
previous
question to team
gets 2. Correct? Then for the next team,
2 questions. 1 mark to team 5, madam.
The mark.
1 mark to team 5, madam.
1 mark to team 5 passed question.
now we have the last team, no, madam?
Yes. Yes, sir. Yes, sir.
No,
Last team, no?
Okay.
Yes, sir. Yes, sir. Team 5.
Now tell
your
us, look at
second
the neck,
question is
the
over.
middle picture, and tell us what kind of effect this deformity has on the face.
Sir, 1 minute, sir. Give me
Basically, the chin and the lips.
This is for team 4,
1
second
minute.
question.
1 minute, sir. 1
question
minute,
for-
sir. I will give a clarity. Madam, please. Actually, team 4 got 2 questions, ma'am. They answered one first question, like medial canthoplasty.
Yeah.
Symblepharon. For that, they will
So
get 2
2
marks.
marks.
And
Okay.
second question was passed to team 5. They will get 1 mark.
Okay.
Yes.
Okay.
So
Okay.
we have 2 questions to team 5.
So now team 5 is the last team, correct?
Yes, sir. Yes, sir.
Okay.
Yes, sir. Yes.
Now team 5, look at the middle picture. Okay, the deformity of the neck, and tell us what kind of effect this will have on the overall bearing on the facial deformity, lips and the cheek.
So basically, what we can see is there's a contracture of the neck here, which is also causing a secondary, possibly a secondary contracture of the angle, the right side angle of the mouth, the commissure of the mouth, and causing lip eversion to a certain extent. So lip eversion is there, sir, because of the contracture of the neck, sir.
Extrinsic contracture of the.
So tell us what is intrinsic contracture and what is extrinsic contracture.
So extrinsic contracture is like the contracture of the neck that is pulling the lip down. That is the extrinsic contracture, and the intrinsic contracture will be the contracture that is at the level of the lip, sir.
Yeah. So what should be the schedule of this operation? When should it be scheduled in overall management, number of operations?
So at first we will release the neck contracture and see the automatic, there will be correction of the lip eversion. And accordingly in second stage, if needed, we will do correction of the intrinsic contracture of the lips and followed by aesthetic reconstruction for the nose and the ears.
Fine. So you get, that is right. Your next question is, tell us about the aesthetic criteria or aesthetic points about the neck. Define an aesthetic neck. What kind of neck? What kind of aesthetic would you ensure in Burns contracture, or generally overall? Which is the most important point is neck aesthetics, which is the second most important.
So neck is only one aesthetic subunit, sir.
Yes,
So,
but what makes it more aesthetic? What you must ensure to make it look good?
so the cervicomental angle needs to be maintained, sir.
Very
And we
good.
need to release the neck contracture. And so basically we can graft the defect, sir, after fishtailing.
That is one. Second,
She should be fully able to fully extend the neck and
able to see the
look
roof.
towards the roof, sir.
what should be visible?
The jawline, sir, should be visible, sir.
Should be visible. Yes, very good. Anything else? Which muscle should be visible?
The
Platysma.
Platysma is not visible.
The sternocleidomastoid.
Sternocleidomastoid is visible. Anything else you want to add on?
The thyroid cartilage.
Very good. Very good. You get both your questions right. Or I asked only one question, no, so far?
No, sir. No, sir. Two questions are done, sir.
Two
Sir,
questions are done.
all teams over, sir.
Yeah.
Done, sir. Done. Sir.
All
Very good.
questions over.
Yeah.
Dr.
Sriva-
Srivastava, sir.
Any final comments?
Nothing much to say. Dr. Bhatt has crafted all questions very nicely. I only want to add that this full thickness graft has been applied at places. Patient needs correction of this line from medial canthal to right ala, right medial canthus to ala. This will also be needed to be broken up. And second thing, the lip might need some fat grafting for its equal thickness on both sides, along with commissuroplasty. And all the things have been taken care of. Thank you.
Thank you, sir. Madam, can we move to the post feedback collection by Umar sir?
Yeah. Meanwhile, judges will compile the marks and it will be announced later. Quick feedback.
And then
Umar
we
sir
move to
is
post
there?
of.
Can I just add one point
Yes, sir.
Sure, sir.
for the students' benefit?
Yes,
When
sir.
you are planning, as Dr. Bhatt was asking, when you are planning a forehead flap for this particular patient, then you must tell also that it is a 3-stage procedure. In first stage, you are introducing the expander. In second stage, you are raising the flap and interpolating it to the defect. And the third stage is the division of the pedicle. So they must realize that it is a 3-stage procedure. They should initiate their answer with this, that it will be a 3-stage procedure.
Yes, sir. Thanks so much, sir. With permission of Madam Lakshmi,
Sir.
may I add a few things? I need to share my screen for that. Is
Sir,
that all?
now?
Yes, sir.
Hello?
You want that post-op photo, sir? That
Yeah.
is there.
Yes, madam. I will
Yeah,
show
available.
if I can show my screen.
Those 2 slides are there in post-op follow-up. That can be shown.
No, there is one more after this, madam. Can I share my screen, madam?
Yes, sir. Yes, sir. You can, sir.
Yes, sir. That is better.
Please allow me to.
Kiran.
Ask them to.
Yeah, please allow me to share the screen so that.
Done, sir, done, sir, done.
Sir, you can do it. It's a multiple sharing.
Now starts sharing. Share.
Okay. Now, in fact, this is how. Can you see that or no? Can you see the cursor?
sir.
Yes, sir.
Yes,
So
yes.
this is how she presented to us initially. Following this contracture was released first and the neck contracture. Because all these scars here, they are creating a vector, especially the upper lip, and there is a lot of show here. So the lip seal is not possible. So in the first stage, the functional things should be taken care of. So this was released in the first stage, this area, as well as certain part of lower lip. And that is how the vectors around this are neutralized. And of course, the neck contracture has been released in the same stage. So that was first operation. Followed by this was the tissue expansion. Now, with regards to the shape of the expander, this is the only one that we had available to us. So where to use it? But ideally, the expansion should be vertical, should be placed in this manner, vertically, or it should be a round expander. Now, this was the classical teaching that you expand the forehead for nasal reconstruction. Now, the current teaching is do not use an expander for forehead flap for nasal reconstruction because enough skin is available on the forehead. You do not need any expansion. And they say that the expanded skin, particularly in case of nose, it shrinks with time. So I would say in retrospect that using the expander in this case was probably a mistake, although that is how we have been classically taught. But the recent teaching is do not use the expander as far as possible. The second mistake that was made in this patient is we used a forehead flap that is obliquely placed in this manner. So the classical, now the teaching, the recent teaching is you should orient it vertically because a vertical skull always looks better. Secondly, if you place it obliquely, you are cutting two arteries at one time and you are cutting some nerves here. So there is a greater chance of post-operative loss of sensation. So as far as possible, orient it vertically. So two mistakes done here. One is use of expander in the first place, which I would call it a mistake in retrospect. Some of us still do it, that is fine. And second thing is orienting it obliquely, that is wrong. We must orient it vertically if you are using an expander. And third thing is we must use a framework when we are transferring the forehead flap. If we transfer a forehead flap without a framework, then that is a mistake. In this case, we did a framework reconstruction, that is an absolute must. So please remember, doing a framework reconstruction later would be a mistake because with that, the forehead flap will shrink. So as far as possible, provide the framework in the first stage at the time of flap transfer. And third is allow enough time. Now look at this. Look at the last photo in the corner. Now can any of the students tell me what is the difference between the middle photo and the right hand side photo? Have they learned something looking at these photographs? The students, look at the middle photo. The left hand side photo is how she looked like. The middle photo is after forehead flap transfer. See the oblique scar, that is not looking good. And one more operation she has undergone, and this is how she is looking now. So what has been done between these two stages and what is the lesson that we have learned in this? It is a basic plastic surgical.
Sir, eyebrow symmetry has been lost.
Any of the students look at the nose and tell me what has been
Cartilage
done.
has
What
been
operation has
placed.
been done. I will show you the next photograph also.
Crush graph.
Framework was
Dorsal augmentation. The framework has been improved and the flap has been debulked.
Look at the middle photograph and look at the right hand side photograph.
Tip is defined.
Yeah, columella strut has been placed. Dorsal augmentation has been
No,
done.
it was placed at the first time. The framework reconstruction was done when the forehead flap was transferred. So what is the difference between this and this? Same thing in the frontal view, the difference between this and this. And
So,
what
flap,
basic plastic surgical principle we have followed in this?
sir,
It is difficult for you to answer, but if you can answer this, I will be very happy.
sir, in a second photo, that is the immediate after healing of the well settled flap, which has more tissue, and in third photo, the secondary after secondary rhinoplasty, the bulk of the flap has been reduced. So
Fantastic, very good.
yeah.
So the lesson to be learned here is when you are transferring a flap initially, you are from which college?
KEM, sir.
KEM hospital, no wonder. Okay. So whenever you are planning the primary operation, we must plan a larger flap. Okay, and this is a contouring operation where the excess tissue has been excised. So it is always easy to excise a tissue which is redundant and get the contour rather than falling short. If you fall short, obviously you can't do anything. The operation is an absolute failure. So whenever you decide the area of the flap or the amount of tissues to be replaced, if you have to err on the side of excess. Transfer excess tissue, nothing happens. Okay, you can always excise this, do a contouring operation, and it will look good. But if you fall short, that will be an absolute failure. That will be the lesson to be learned from this. You agree with me or no? Bhattacharya sir.
Yes, sir.
Yes, sir.
Bhattacharya.
Yes, Dr. Bhatt. I
Yes, sir.
totally agree because there won't be any answer once you fall short.
Yes, sir.
Yes,
Then
sir.
you start adding from the adjacent area and start compromising, and the result will be also compromised.
Yes,
Yes.
sir.
Yes.
Thanks so much, sir.
It's always you can trim it and play with the tissue.
Yes. And second thing that we have learned is look at the scars, how do they settle well? Look at everything settles down with time. So time is the best healer. So we should not hurry up with the operations. Allow enough time for the tissues to heal. Now look at this graft here around the lips and look at the graft here. It looks reasonably more settled. And is almost the color. Of course, it is more pigmented, but is blending well with the rest of and even the cheek is blending well. So if you allow sufficient time, do not hurry up with the subsequent operations. At least allow 1 year between the two operations. I think the result will be better. So patience is a virtue. If we wait for a longer time, obviously we get enough time for the tissues to improve and settle down.
And just one more thing I wanted to add, that when you are detaching the flap, you have sutured it adequately, and when you are detaching the flap, I think that is the time when you should adjust the tissue very well, keeping in mind the units of the nose.
Yes, sir.
For example, here also you have done that, because if it would have been only the supra-alar area or the tip, and here in the third one, you are showing that it is going almost up to the root of the nose.
Yes,
That
sir.
means you might have used the pedicle part very genuinely.
Yes, sir. Absolutely. Yeah. And
And
that is how she looks in lateral view. What
yeah,
is
that's why in
redundant
the
now?
lateral view it is looking so well. You have utilized the pedicle pad very well
Yes, sir.
before detachment.
Absolutely. Yes, sir. Thanks so much.
Turnover for lining.
Wonderful, sir.
Madam, can I move to the other post-op?
Feedback. Oh, yes, you can show.
This is Nikhil Panse sir, madam. I think Panse sir is not there.
Sir has left.
No,
This
ma'am.
is
I'm here.
Sir, would you like
Sir
to a little give the details of the case?
Yes, just a quick comment. If
Yes.
I were to do this case again at this point of time, I wouldn't go ahead with a skin graft because, as you can see, it is going into recontracture. Although we were able to achieve a complete release, this is going into recontracture. I would have preferred giving a pedicled ALT for the groin, and rest of the areas we could have probably grafted. Surgery was that way fairly easy. As you can see, the markings are already there on the image. We went on incised and did a complete incisional release and then resurfaced it with a skin graft. So surgery was pretty straightforward, and Bhattacharya sir has already in detail described about the intra-op procedures, possible complications which can occur, and due care which needs to be taken. So we all did that, and yes, functionally it was quite gratifying for the patient.
Thank
So
you.
that's all from my end, ma'am.
This is the third spotter. I think Durga ma'am.
Durga Karki.
Yeah. Actually, in this patient, as I told you, we give some time. And then after the debridement, we initially in the pre-op just 2 days before, we went for MRI and angio. And can you imagine just 5 millimeter below this, that necrosed area were the carotid vessels. So we just discussed with the radiologist. And then we very carefully we debride. Earlier you saw those, dead lying muscles, sternocleidomastoid. We carefully debride very gently, and almost the video is not there. Almost the pulsations were there. So after debridement, we did this pec major flap, because all these, this is devoid of sternocleidomastoid. We have to give a cover so that, for the future. But the flap was so big, we have to include the nipple areola. Later on, we planned for the excision, but the patient had some work. And now we are planning for this ear reconstruction. And patient has, he, as ma'am said, like we have to rule out other also, the exit part. He had these amputation, both bone electric burn. So amputation was done. With the artificial limbs, he is working, he is walking. His rehabilitation is very good. For this year, he wants after a year or so, he will come and for this reconstruction. Rest of the neck movements, everything all right. And patient has a quite, I can say a good outcome, post-op outcome.
Thank you, ma'am.
Because if we'll keep this, this is the front view. This area you want to, we also advised him, but due to his some personal inability to come, he didn't come. Because this, in these cases, we cannot wait too long also, because anytime, there is a blowout from the vessels.
Yeah.
So we have to be very carefully balanced between these two acute and the subacute, borders. We have never to cross so long or too early, because early there is a lot of inflammation. We cannot have any, border between the viable and the non-viable tissue if it is acute. We cannot decide, it is viable or not viable. So we have to give some time and then act accordingly.
Now, this was discussed.
Dr. Umar is there?
Feedback collection, ma'am. That's here left with that.
Rohit? If Dr. Umar is not there.
Umar.
Hello? Hello?
Dr. Umar. I think
Hello?
so. Yeah, you are audible. Umar, please continue.
Okay. Good evening to all.
Yeah, good evening.
It was a nice session, quite exhaustive and long, quite informative. Let us, without wasting time, we'll start with taking the feedback from the panelists. So let us start. Dr. Nikhil, you can start.
Yeah, definitely. I think I've been on this session quite a few times, and as a participant as well, and a panelist.
Yeah.
And I think this is a wonderful initiative, and hats off to the entire organizing team and Lakshmi madam for doing this consistently. Doing it once or twice is a different thing, but doing it consistently for so many years now for different forums, for cleft, for burns, for hand. So it's a really interesting thing. And as you can see, the number of participants, initially at the beginning, they were 50, now also they are 50. So that
Yeah.
itself indicates that this is a very absorptive thing, and you keep on learning new things from the different faculty when they present their point of view. So I think thanks a lot to the entire organizing team for doing it in such a interactive way and doing it consistently. Thank you.
Thank you, Dr. Panse. Now, Durga ma'am. Durga ma'am is there?
Yeah, madam is.
Yeah. It was mute. Yeah, I can say that, it's a great platform. Not only for the, PGs, they have a great advantage of having experience from all over the India, the faculty members. And because sometimes, some faculty is doing something and some has a different experience. So it is a compilation of all over India, their concept and the recent advances. And at the last or at the start, I can say a big, congratulations to the team, because there is a good coordination between the whole of all the members of the team. From the compilation of the cases to the, all coordination. And Lakshmi ma'am, she's the, we can say, very good organizer, and she's such a hardworking. Even yesterday at 12 o'clock, I just gave her a message and she replied, she is such a hardworking and, devoted personality.
Rightly so, rightly so.
Yeah, but, everybody is doing something, some symposium, some seminar, but she's, into it, and she is involved in these the task, whatever it is. So I must say it's a very good platform for the PGs. They have so much experience, they have exposure. Our time, we were not aware of कि वहाँ पे कैसा काम होता है या क्या, what are different views of other faculties. Only in the conferences, we can go and
Yeah.
attend. And so it's a very nice platform, not only for the residents, for faculties also.
Thank you, ma'am.
Congratulate. Yeah,
Thank you, ma'am.
especially the madam.
Arun sir.
Thank you, ma'am. Thanks a lot.
Thank you, ma'am. Dr. Arun Bhatnagar sir.
Yes, I go with the same words as Durga has said, because we had been into the practice for so many years, and we have acquired the experience in different kind of people with there are different kind of demands of the patient. Sometimes they want total correction, sometimes they just want to get away with functional deformities only. So it's a good kind of learning, comprehensive learning, not for the students, for we people also from different regions of the country. And I think it's a great experience of learning never ends. I'm still learning, frankly. I have to.
Thank you, sir. Thank you, sir. Shailesh sir, Shailesh Ranade sir. Sir is here.
Yes, I'm there. It was the first time that I participated as a panelist. And I
Most
thank
welcome,
Dr.
sir. Most
Lakshmi.
welcome. Yeah.
Dr. Lakshmi is really hardworking. Last night, Durga, you were talking about 12 o'clock. I messaged her at 12:45 a.m. because she wanted my one slide and we were chatting. So she puts in a lot of
At that time,
sincere
she was
hard work.
waiting for your
And
slides.
really appreciate the entire effort. And it's really, the students should really thank, as well as we faculty should thank the team, because it's an experience for the students. It's like a mock exam for them, where there are so many panelists from all over the country asking direct questions. And I think it's very useful for them who are especially exam going. They get ready-made so many questions which can be asked actually in their final exams. And it's
Right.
a beautiful teaching modality, because in all specialties doing such a kind of a work, and I think it's an excellent affair. And I think the finals, I'm going to be really watching the finals. The students are also well prepared and they really answered quite well. So really appreciate the effort of the students as well. And overall, it was a pleasing experience. It is exhaustive, but very pleasing. I did not move from my chair for all these 2.5 hours.
Thank you,
Thank
sir.
you,
We'll
thank
invite
you.
you again and again. Now you will be a regular
Person.
Thank you.
faculty
Can
for
I
us.
can
Thank
I
you, sir.
add one more
Sure,
thing?
sure,
Yes,
sir.
sir. Yes, sir. Please.
She has been so much determined and persistent, because she has been after me to participate and share the slides. Really, it was the last moment. It was her efforts I could get into this platform. I really
Thank
appreciate.
you, sir.
Thank you so much.
Sir, it is all for the Pan India program For students, I think students are really benefited, but I think the faculty is more benefited. May take for me that we are also learning at the same time while teaching. So I can say it is a learning platform, not a teaching platform. So we all learn from each other. That is the beauty of this Plastiquest.
Just to add one more point, there may be definitely one loser. There are multiple losers and one winner probably.
But competition will be neck to neck today.
Yeah,
We'll
but I
later on.
really appreciate effort of all the 6 participant teams, and they really did excellently well. Doesn't matter who wins and who loses, the effort was magnificent, and I think we should applaud all the 6 teams
Yeah,
for
very
doing a really
nice.
good effort.
Yeah, well prepared. Yeah.
They're putting
Any
a
other
lot of
feedback
hard work.
from the judges, other panelists? Please.
Only one thing, Dr. Umar.
Yes,
that
sir.
we are raising the bar higher and higher.
Sir, that's a good thing. That's a
Yes,
good thing, sir.
sir.
Yeah.
We
And
are all
all
working
praises
Many,
together.
for
many
Dr.
things are there
Lakshmi.
which we are not knowing. Really,
Yeah.
always you learn by attending this program. Really.
Yes. Yes.
Sir,
Thank you,
sparing
sir.
3 hours, but getting 3 years knowledge.
I think 300 books are there.
30 years
Yeah.
of your experience.
Really,
So,
really. Any other person
that
want to
is
share
the
something or
most
feedback?
advantageous thing.
I think
Really,
final
really.
comment by Dr. Bhattacharya.
Yes, sir. Yes,
He
yes.
is the head of our unit.
He's the Pitama. He's the Pitama. He will
Pitama.
do the final word.
Actually, this
Blessings.
is truly a national program because the students are from different departments of the nation as well as the faculties. That's number one. Number two is that our engine have lot of fuel to pull the bogies for years.
Yes, sir.
That is Dr. Lakshmi and her team. So it is a very
Excellent
strong
team, sir.
strong engine with lot of fuel, and that's why it pulls on bogies, and the bogies are increasing. And the third
Thank
thing
you,
is
sir.
I wanted to mention is that I acknowledge the knowledge of the students. They have made effort to come to this forum. So it's beneficial for them certainly, but I hope the departmental heads will tell others departments also, so that the participants number increases, because it is for their benefit, and not only for the exam but also for the future their career and practice. So they learn lot of things, a lot of practical things, and what the experts did when they show the pictures post-op at the end of it, then
Yes.
you see, in plastic surgery it's a surface surgery.
Yes, sir.
It will be never 100% most of the time. So you have to see that where they were, the first picture and the last picture. So that gives you the impression that even in the best hands, especially in the cases of burn patients, that where do we reach? And because the expectation of the patients are very, very high, they want to be as before. So and therefore the counseling of the patients and the attendants, maybe the patient later with the deformity, we must say and write on our papers. It should be documented that explained adequately to so and so. So then the whole picture ends nicely, and they appreciate our effort. And being a part of this organization, I am absolutely privileged.
Thank you, sir. Thank you, sir. I would say most important thing and the beautiful thing about this is that whenever we invite any faculty to contribute and they respond so positively and so promptly, it is really, really, I can say not only wonderful, it is amazing.
And
Yeah.
and the other point to continue is that the sequence is made in such a way, very cleverly, that nobody can leave till the end.
Yes, that is true. That is true. That is true.
Yes.
That is true. So, if Angela madam is ready, we can go
Madam
about.
already compiled very nicely. She is good
Our
asset for
national
us.
scorer. Madam is the national scorer.
Yeah. With
Good
lot
evening,
of
madam. Good
patience,
evening. Good evening. Good evening.
madam.
It is really a challenge not to. it's not only for the contestants, but for us also, sir.
Yes,
It
yes,
was
yes, yes.
nice participating in all these days. It was a pleasure being with you all and learning a lot, actually learning a lot. It was nice.
Really?
And now for the final program, we are eagerly awaiting. And let me announce the Team 1, Shri Gangaram Hospital, 16 marks. Team 2, Faith Mumbai, 36 marks. Team 26 marks. Team 4, Ames Bhubaneswar, 23. Team 5, Southeastern Railway, Kolkata, 23. Team 6, BML, 18. So actually, the top scorer in this thing is Seth Mumbai, and
Vinita ma'am's team.
followed by second is
Jipmar Pondy.
the Jipmar
Puducherry.
Pondy, 26. And third, this thing is tie between Ames Bhubaneswar and Southeastern Railway, Kolkata. Then again, BMC. Almost
Bangalore.
3 pan are closely fighting, and the last 2 are also closely fighting.
All are neck to neck there, no?
It's nice to neck to neck only.
We can make out
I
all
don't know.
the
Congratulations to all. Congratulations to all.
Congrats
It is
to
just
all.
a
Definitely,
winning
they
and
have
losing.
done extremely well.
Yes, ma'am. Yes, ma'am.
And congratulations to
Thanks a
Vinita
lot.
ma'am. Her team is coming on the finals.
So team 2 and 3 will go for finals. Congratulations to them. And
Congratulations to all. And
we
especially,
appreciate and congratulate all the participants. We all are
yes, ma'am.
gainers.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
And Vinita
A
ma'am has
big
posted
applause
invitation to
to
all to be at Goa in the coming week. So you are welcome to the Goa for the APBC. So let us go to now Devi sir for the vote of thanks.
Before,
sir.
Devi sir.
before Dr. Devi sir says, I just want to say congratulations to the winning team, but I want to say for the losing team, don't lose heart and give a big smile. Don't worry, this is not end of life. This is
Yeah.
a small competition. So the losers, you don't have to be so disheartened. Just give a big wide smile and come back again with a better preparation next time. There's always ups and downs in such kind of
Absolutely, sir. Absolutely.
Yes, sir.
participating in the competition is more important than
More
winning or
important.
losing.
Yes.
So I think you have done a great job by participating it. So I think don't lose heart, don't be disheartened, and come with winning combination next time with preparation. All the best.
Thank you, sir.
They have already
Devi sir.
won, sir. They are in
Yeah.
YouTube all the time and guiding and becoming their for juniors. So all these are uploaded in YouTube and for their future use also. So
That is the beauty. That is the great thing about this.
actually they are becoming teaching modules. So they are helping their juniors also.
No doubt about that.
Yes. By coming forward, they became part of our sessions. That is most important.
So coming to the end of this session, Plastiquest session, I would like to give the vote of thanks. First of all, I would like to thank the participants this time.
We congratulate you. Your team won and reached final.
The second team is the Devi's team, na?
Yeah. That's why he
That
was
is great.
removed from the common team yesterday.
Yeah.
Before sharing the spotters, I deleted him from the common team.
Yeah. I was seeing that, na?
Yeah.
Yeah.
Anyway, I didn't know
Devi
anything.
was out because of spotter
That's why
incident.
he is not aware of all the any spotter. There is no communication with him only.
Now we are seeing him here online.
Yeah.
Hello, Devi, please go ahead.
Yeah. First of all, I would like to thank all the participants, our PG participants.